Hi, good morning. So we're going to start with the last topic of yesterday's, which is AI in clinical practice by Dr. Janani Murtidharan. Janani was unable to join online as she's out of the country, so she's prepared a recording. I'm going to play it now, and then we'll start after that with our regular thing. So thank you everybody who joined now. This will also be recorded, so people who join later can see it. So I'm going to try and share the screen, and we can start. So thank you.
Good evening, everyone. My name is Janani. I'm a clinical informatician at health tech startup called Atropos Health. I'm a clinician, but I was always interested in technology and medicine, and I veered off the clinical path to get into this and learn a little bit more about this. Before I start my talk on AI tools for clinical practice, I'd like to thank Anjali for this opportunity and also apologize for this digital recording instead of being able to do the slide. So I'd like to start with my learning objectives. So I want to talk about learning the language of AI. I want to talk about the tools available and what their use cases are. I also want to talk about how to evaluate if a particular tool is good for your clinical practice. And last 1 or 2 slides on digital safety and ethics of using AI. So learning the language of AI, we'll look at what is AI, types of AI, and why do I need to learn the language. Starting from what is AI? AI is artificial intelligence, and it's basically making a computer do tasks which are commonly associated with human intelligence. So one thing I'd like to call out here is what is not AI, because sometimes I feel that we as clinicians we don't understand the difference very well about what is programming versus what is just what is just programming versus what is artificial intelligence. One way I like to think about it is if you're giving your computer explicit rules. For example, the few lines of code that you can see on the slide here. I've told the computer how much the user should give insulin if a glucose reading is such and such, right? So here I've told the computer exactly what to do, and I've put in explicit rules. And the computer is doing exactly what I told it to do, and it will not do anything less or more than what I've told. And that is programming, and that's not considered intelligence as such. So now that we understand what is artificial intelligence, there are multiple ways of classifying artificial intelligence. One easy way to do it is to think about what is the function of that AI model, right? If it's a narrow AI, that means it can do one task, and it can do that task very well, but it can do only one task. I would think of it as a very, very narrow subspecialist. Let's say a neurologist who specializes in epilepsy. So it can tell you what drugs to prescribe for epilepsy, but if you step out and go a little broader and say, here's a patient who is coming in with a snake bite, not necessarily the best performance, right? So narrow AI is like a really special subspecialist, whereas general AI is a multi-purpose AI, kind of like you and me in internal medicine and primary health, where we're actually trained to handle anything that's thrown at us, right? That's one way of looking at AI models, depending on what the function is. The other way to look at the AI model is how has it been trained. So AI is basically machine learning, and a subset of that is deep learning. The way I like to think about machine learning is the machine is learning from experiences without being explicitly programmed. Means it's just programming. Here, the machine is learning from experiences, learning from data, and picking out useful patterns on its own without being told what to do. And it uses this information and wisdom, if you want to call it, to learn how to do a task. And that's what machine learning is. Now, it is important for us to understand the difference between machine learning and deep learning. The last row of my table talks about what machine learning technology is and what deep learning technology is. So support vector vector machines, random forests, even regressions are typically traditional machine learning, whereas deep learning is the neural networks that everyone's talking about. So convolutional neural networks and GPT, right? So generative pre-trained transformers, like your ChatGPT, are considered deep learning models. But let's take a step back and look at what is actually the difference between machine learning and deep learning. So deep learning is actually just a subset of machine learning. Machine learning learns simple patterns. Think of it like a 5-year-old or a 6-year-old. Okay, you have to give it very structured data. This is this cat is walking on a road, or this dog is barking at somebody. So very structured, very simple patterns it's able to pick up, and there's greater interpretability in machine learning data sets. So if it comes out with something, you're able to understand why it's saying what it said. And you can feed it small data sets, and that's good enough for a lot of the traditional machine learning models. It definitely depends on your objective and what you're trying to do with the model. But usually smaller data sets are typically enough for a machine learning model. And it can't handle multimodal data very well, right? So usually, so just to recap, structured data, it can recognize simple patterns. Smaller data is good enough. Data sets are usually good enough, and I can understand why the machine learning model is giving the output it's giving, typically, right? With traditional machine learning models. Whereas deep learning is like a teenager, right? There's complex, abstract patterns. The data is if the data is unstructured, right? If it's image, sound, text, it can process it. It can do both task specific or it can be general purpose. Most of the general purpose models are deep learning models, and it requires large amount of data sets to be trained. And you can throw all kinds of data at the deep learning model. You can throw image, sound, and natural language as input data for deep learning models. So the reason I put up this slide is, let's say that you have a problem that you want to work on and build a model, right? When you talk to, you don't, as a doctor, you don't really need to build a model yourself, but you need to have that vocabulary to convey to a engineer or a data science person. This is the data I have, it's structured. I have a small data set, and I'm looking for greater interpretability. And I expect usually simple patterns to be what's needed to, classify this image or classify this text or whatever it is, right? So I would like to use this machine learning model. With deep learning, if you have large amount of unstructured data, then this is where deep learning models would be useful. This is kind of important to know the difference, so that in case you're thinking of building a model, you'll know which direction you have to steer toward. All machine learning models, and this includes all deep learning models as well, can either be descriptive, predictive, or prescriptive. I've given an example for each, but typically what's important to remember is the risk kind of goes down as you stay at the top. So descriptive models have a little less risk, whereas when you become predictive and prescriptive especially, it carries higher risk, right? So there the machine is actually giving you suggestions and telling you what to do, as opposed to just saying, this person has fabric retinopathy or this person doesn't. It's not just a classifier like how it is in descriptive. Right? And the previous slide, I thought it was important to know, because when you're looking at a model, so the way I want you to think about it is, are they using machine learning method or are they using deep learning methods? And is it a descriptive model, is it a prescriptive model, or a predictive model? So start thinking about it in that way when you start reading papers on AI models and stuff, right? So that brings me to my next question: why learn the language, right? So I spent so many years learning anatomy, physiology, biochemistry. Now you're telling me I need to learn computer science as well. So one thing that I see in the market is they have all these solutions for healthcare, right? Like your MedPalm, your GPT, etc. Whatever the solutions are available. Very often we kind of try to fit it to our needs, right? You as a doctor in a primary healthcare setup, or me as a doctor working in a tertiary healthcare setup, and in India specifically, our needs are very unique and specific. Our problems are specific. But instead of taking the problem statement and trying to find a solution, what we're trying to do very often these days is taking a solution and trying to fit it into the problem. And that's not what the problem solving methodology endorses, right? So we actually need to go the other way around. We need to identify the problem statement and work with engineers, data science folks and work together, understand the tools, and come up with better solutions. So this is why I believe it's important to learn the language. And one of the reasons I stepped out into a startup is also to get fluency with the language, understand what it is people are doing. Not all of you will be interested, which is fine. But for those who are interested, there are a couple of resources I recommend. One is this course that I'm doing right now called Code in Place. It teaches you the basics of coding in Python, but I think actually coding as a skill is not something doctors need to learn. It's just a way of thinking through the problem that I think is a very valuable life skill and a very valuable skill in general that will be helpful if you're interested in technology. And Code in Place runs like an 8 weeks course where everything is free. They have a lot of material. They have online classes as well to support you, and it's offered by Stanford University in case you want to look it up. The second place is Data Camp. Data Camp also has a lot of information on data science, statistics, machine learning, whatever you're interested in tech. It's a good place to start. The third suggestion I have is for those of you working in primary healthcare, there are a lot of engineers and data science people who would love to work with you, right? Attend health tech conferences, start teaming up with them, seeing what problems you can solve, what data you guys can work with. And that's a fantastic way to solve your own problems and build your own models. Now, coming to my topic proper, which is tools, AI tools in clinical practice, I focused mainly on two types of tools, so large language models and multimodal models. Multimodal just means that you can throw text, you can throw image, you can throw audio at it, whatever it is. All of these models, like we saw before, are deep learning models. So we'll talk a little bit about large language models, and we'll talk a little bit about computer vision models. This slide, I put it up here because I'm pretty sure everybody on this call has used ChatGPT, but most of us probably understand how it works, but it is important to kind of reinforce this. All your LLMs are trained on vast data sets from the internet, right? And what it does is it learns facts and patterns from these vast quantities of text. For example, if I say, if I'm the computer and I'm the large language model, and I read a sentence, right? Patients with diabetes have elevated blood sugars, right? It's a sentence I've read, and this sentence I'll read it again and again in different places, right? I'll read it in patient support groups. I'll read it in PubMed papers. I'll read it in textbooks. I'll read it in Wikipedia. I'll read it in multiple places. So this is a pattern that I've learned to recognize, and it's a fact that I have learned. But how have I learned it? Have I understood it, or have I by-hearted it? The way I'd like you to think about it is it's kind of like by-hearting it. I've by-hearted that patients with diabetes have elevated blood sugars, right? And what happens when the large language model, when you ask it a question, it's got a whole bunch of these facts and patterns by-hearted, right? So when you ask diabetes, what happens in diabetes? It remembers patients with diabetes have elevated blood sugars. So the word diabetes is a vector. It programs it into a three-dimensional space as a vector, and it looks at closely linked words to this vector. So diabetes, sugar, elevated, all of these are close. So it pulls that out and tells you diabetes patients have elevated blood sugar, blah, 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 and it can go on, right? So it's kind of like an auto predictor. It's predicting what the next word in sequence is. And this is a very important concept to understand because one, the internet is also full of wrong facts. So that's one of the reasons it can also spew out wrong information, especially for things like nutrition, right? There's 100 different people writing 100 different things about nutrition, what's good for you, what's not good for you. So be cautious about things like that, where you know that wrong information can be available from the internet. The second thing is, remember that it's a vector pattern and it's looking at closely linked words, and it doesn't pull out the same information every time. So if it's diabetes and it has elevated blood sugar, next time it might look here and say diabetes and ketoacidosis also comes nearby, so it returns ketoacidosis. So that's why the output that you get in LLMs is not the same every time, and you can get different outputs with every question that you ask. A little bit about computer vision models. Computer vision models, here the input is usually images. And what happens is, usually for traditional machine learning at least, we do something called feature extraction, where we either label the features. I'll say that, this is a this nodule is probably likely to be a malignancy because it's got this particular speculation or this element of calcification. So I'll label the images and teach it to the machine. The machine learns it, and then I'll ask it to identify in new sets of images, right? So that's called the training set, the testing set, and the validation set. So I have, say, 200 X-rays where 100 X-rays are CA lung, 100 X-rays are normal. And I've labeled all the CA lungs and said, this is why it is CA lung. And then after the model looks through those X-rays again and again, but again and again it's called an epoch. After it finishes that, and I think it's got a good understanding of it, and these are all based on numbers. There's something called as loss of optimization function, and based on that number, we say that it's learned this model well, right? Yeah. Sorry. Based on that, we've said the model is trained quite well. Then we give it a testing set. Let's say I have another 30 images of X-rays, and I see whether it's able to perform well. And once I think that it's performed well, I give a fresh set of X-rays, which the machine has never seen, and that's my validation set. Here, I can do an internal validation with X-rays from my center, or I can do an external validation where I pick up X-rays from, say, another state and feed it in and see if it's still able to identify, lung carcinoma well or not, right? So if I label it well, that's usually traditional machine learning. You can also just give images and say, you figure out what the difference is between the images and tell me what the categories are. And that's more of deep learning. But that's traditionally how computer vision models work. Let's quickly go into some sample use cases. Sample use cases you can think about use in community health, clinical care, patient care, administration, and research. Just to keep it brief, I've focused on the first two, community health and clinical care. But if you look around and look at AI models, there's models for each of these, patient care, administration, research. Administration is one of the less ethically challenging groups. So like saying that making models to make sure that your patients follow up, right? Like might track patients, do some sort of calculation to figure out which patient is less likely to follow up and make sure that they are given warnings or something of that sort. So administration is a little less ethically weighted, but obviously community health, clinical care is more weighted. Patient care can be patient-facing models, where the patient uses an AI model to figure out, like, for example, symptom checkers, right? There are dozen symptom checkers available on the internet that patients are definitely using. But let's focus on the community health and clinical care for now. So one example for community health is infectious disease surveillance. This particular image on the left is a COVID outbreak from February 2020, and they figured out which place is the epicenter for the outbreak based on information that people are posting on Facebook, on Twitter, based on phone calls made to hospitals, to emergency rooms, a whole lot of information fed in, and based on that they were able to build a model to kind of track and say that this is where the epicenter is, so that quarantining measures could be put into place. I also tried to pick out a few examples from India. This is from Bangalore, and IIC was working on this project where they were trying to predict and prevent dengue outbreaks depending on the data that they were capturing. So that is one use case of AI models where you can use it for infectious disease surveillance. Another use case, and I've just really picked one example from each. You can go into community health and you'll see 500 different applications. I've also tried to keep examples that Indians are working on to give you that idea of what is actually available and what people are working on right now. So this is from community health screening, and this is an AI model built by a health tech startup called Miramine. They're a Bangalore-based company, and they do thermal imaging to pick up breast cancer in women. The advantage of this is that there's unlike a mammogram, the woman doesn't need to undress in front of anybody. She goes into this enclosure and an image is captured, and then based on the image, the person is advised on what triage she fits into for breast cancer, right? It's like a screening tool for breast cancer. And this is one of the use cases for community health screening. The second use case that I'd like to highlight is a smartphone-based screening application for glaucoma. This is actually developed by IISc. One of the professors in IISc actually gave a very good talk on this 2-3 weeks ago. And what they're doing is they're based on the fundal photographs, they looked at the cup-disc ratio and a lot of other features in the fundal photographs and said that this person has a high risk for glaucoma. And they're planning to deploy it in, primary health centers, places where obviously ophthalmologists are few and far in between, and make sure that patients are picked up early because glaucoma, as we know, again, is a major cause of blindness. When it comes to clinical care, there are tons of applications again, just like community health. One of the applications is a little bit of administrative role where this company called Nuance has an app where the patient and doctor conversation is continuously recorded. So here the input is audio, like what we were talking about. The model generates notes, so it definitely cuts down on time. And also the doctor is able to have a more face-to-face conversation with the patients, which is not so much of a problem in our country, but in Western world where it's all EMR, the doctors do spend a lot of time behind the computer as opposed to interacting with the patient. So this is another administrative clinical care time-saving model that's already in place. Another model in clinical care is more for, I picked one which is more for primary healthcare. Here is the computer vision model. That's what we spoke about before. And here you can see that a smartphone is attached to a microscope and it's taking images. And what it's doing over here is it's able to identify if what is the like culture sensitivity report for this patient. It's able to look at the discs and see what the distance of clearing is for that particular antibiotic disc. So it's able to generate a culture sensitivity report, which is, not something I can do for sure and would definitely require a microbiologist. But in, again, places where there is lack of staff, this is one of those tools and models that can be applied. This particular article, I think, was from NEJM. Here's another computer vision model where this is something that many startups are working on, where there's automatic reading of the ECG and a report is given. One of the Bangalore-based companies, Tricog, is doing a lot of work in this. They're also working on echoes. So a technician takes the echo. There's no cardiologist, but the model actually generates an echo report. A lot of these reporting actually, like for example, the echo report, there is a cardiologist in the loop. So even if the model generates the report, there is a person in the loop who's checking and making sure that it's okay. Because right now we're not at the point where we, take the model and rely on it 100%. Also, there's a lot of ethical questions about, in case the model is wrong, who takes responsibility. So a lot of these models do employ a human in the loop. But you need to also think about it's like an additional person looking at your ECG, right? That might be okay if you're a junior person and that additional person is a senior. But if you're a very senior person and you're going to look through ECGs and echoes very quickly, that junior person who makes more mistakes may actually slow you down. So it depends on the scenario. It's not a this is correct, this is wrong. It depends on what scenario you're in. And if that AI model wasn't there, what is the consequence? That's the way we as doctors at least need to definitely think about these. Coming to my area of interest in clinical care, my area of interest is in clinical decision support. How do I support doctors who are taking clinical decisions in a better way with this use of technology? And the company that I work with actually deals with this, and I want to just go into it very quickly. So we have a large amount of patient data. We have like 10, 15 crores of patients' data, and we have their diagnosis, we have their prescription data, we have their labs, that kind of, we have what procedures were done to them, all neatly tabulated. So these are actually a lot of machine learning models that we use. And we provide something called as informatics consult. Think of it like how you would ask a cardiologist for an opinion on a patient with heart failure, right? You're asking them for a consult on this. For someone where you don't have guidelines to guide you on what to do, if you want to look at your past patient data, like if you want to look at your 10-year, 15-year patient data, and based on that information that you've collected, give you guidance on what to do next, this informatics consult is a good place to go. And one thing that we do differently from your traditional LLMs, we learned in the previous slides that large language models learn from data sets of the internet. Okay? Here, the models that we build, the one we are building is called Chat RWD, which is chat real world data, and this also relies on vast data sets like your LLMs. But we add another layer where we return answers based on the data sets. So, for example, if I ask the model how many patients with diabetes with HbA1c of 7 on an average develop diabetic retinopathy within the next 5 years, right? That's a question you can get off the internet, or if you have your own data set, you can answer that question from your data set. So what we are doing is we're doing something called as RAG, or retrieval augmented generation, where the answers are coming from data sets. Another useful website, which in case you haven't used as a good resource, is Open Evidence or Perplexity, which also uses RAG. But so instead of ChatGPT, which relies on large amounts of insurance data, this Open Evidence and Perplexity are they look at RAG from pre-existing evidence sources like the PubMed, etc. And I'll show you an example or two about this. But yeah, so in case that wasn't very clear, so what we do is informatic consults, and what we do is we provide suggestions for when guidelines don't exist, and if it's a question that can be answered by looking at retrospective patient data. Some of the possible questions that we can do are like a 60-year-old male with a CLD patient count of 60,000, has a new ischemic stroke, started on antiplatelets. So what proportions of these patients develop IC bleed in 10-year follow-up period, right? So if you have good patient data, continuous patient data, 60-year-old later 60,000, has ischemic stroke, and what was the chance IC bleed, right? So that's a question that we answer. Some of the other questions we can answer, I put up here, like the difference in incidence of CID between the two. There's a lot of literature available about this, but in case you want to ask it about a specific age group or specific patient, specific platelet count, this is a good way to find out this. And I think we also build on ACE, that's our cohorting engine, and basically it shows how we take code and we generate cohorts. Here, for example, we were looking at patients who were who had a history of diabetes with no history of stroke and who were started on glipizide, and we looked at how many of them developed stroke. So you could see that from the previous slide, we had around 43,000 patients started on glipizide, and 50 of them developed stroke. So it's a fairly small number, but in case that was a question that you were interested in, this is how we'd go about it. Now, quickly moving on to LLMs, I've just put in a few questions that I've asked and what kind of replies I've got. And I just want to highlight one or two things from the slide. You don't need to go through any of this. But my question was, a patient is having gross hematuria, CT abdomen pelvis was normal, cystoscopy was normal, but there is hematuria, both in microscopy and gross hematuria. The CBC metabolic panel is unremarkable. What's the differential? And that's one of the questions I'm sure you are also asking in your clinical practice, right? One thing I want you to pay attention to is there is no patient identifiable data here that I've put into my ChatGPT or whatever LLM you're using. There's no way to know what that patient is. I've not put name or address or any sort of identifiable characteristics for the patient. And this is one good way of asking the question. This is ChatGPT's response. It actually gave me 4 pages of differentials over here. Another LLM that I was telling you about, this is from Perplexity, and I've put in the same question, and you can see that this is one thing I do recommend. Here's a differential diagnosis, and it was similar more or less to what ChatGPT spewed out, but it also has resources like PubMed articles or whatever articles, Medcape, for example, on where it's getting this information from. And especially for a question that you're not sure about, I would definitely recommend looking through these resources once to make sure that your LLM hasn't hallucinated or come up with wrong answers. You can also get clinical decision support about images. This I would urge you to be very careful about. This X-ray is actually my grandfather's X-ray, so I'm looking that out. But with his, but it's a patient that you're dealing with. Putting out their images, especially if it's identifiable on the internet, is something that you should be very careful about, and we'll speak about it in digital safety. But I put this X-ray on ChatGPT. And it kind of correctly picked up that this is probably an X-ray with ARDS versus pulmonary edema. A prompt. Okay, so for the same X-ray, I said 65-year-old male with cough, breathlessness in 1 week, history of alcohol use disorder, with elevated itchy erythematous patches on external aspects of forearm, and the diagnosis it gave me was malaria. So one thing that I want you to be careful about is sometimes when you're using prompts and this elevated itchy erythematous patches, it could have been anything. I mean, it could have just been eczema that he's had for a very long time on his forearm. And that is what it was. But there's a kind of, honestly, the best way to learn how to do a good prompt is just keep throwing prompts, seeing all the options that come out, and then using your critical thinking to figure out what makes sense. Even referencing the articles or looking up your own articles to figure out what makes sense and what doesn't. And that's something up here just warn you that be wary. So you need to be able to critically think about if this model makes sense or not. And there are lots of useful checklists available on the internet for you to kind of go through it step by step to figure out if it makes sense. But three important things, just the key things that I want to highlight, is look at model generalizability, right? If it's a model that was built in, say, Oxford in the United Kingdom, right? And I try to use that model in St. John's of Bangalore. Is that model going to work just as well? Is the population that it was trained on going to be the same? Can I generalize the findings that the Oxford model had to the findings that my patients in Bangalore have, right? So these are some of the questions that you need to think about. Is the model generalizable? When they publish information on these models, was this done in a multi-center fashion, or was it done only on their own data set? So things for you to think about when you're evaluating if this is a good model for you to use or not. Second thing is, what is the inherent bias in the model, right? Data, whatever data you take, however good quality it is, there will always be some sort of bias, right? For example, let's take the question that I asked previously, right? Let's take the question about warfarin versus dabigatran, right? In India, typically dabigatran, everyone's paying out of pocket. So dabigatran is much more expensive. So a patient who is able to afford dabigatran may have come for more follow-ups. So, yeah.
Hi, sorry, that's going a little over time now. So we will start with the regular schedule that we had for today, and then we can share the PPT with you later. The first talk we have today is Dr. Luke Salazar, who's an associate professor in psychiatry. Luke, if you're online, can you start now, please?
Hi, good morning. Thanks, Anjali. Are my slides visible?
Yeah, they're visible. You'll get control of it now, Luke.
All right, thanks. So, all right. Okay, good morning, everyone. So, thank you to the organizers, first of all, for giving me this time. And it's a privilege to be here. I see a lot of familiar names here. So, I hope the idea of this talk now is not to sort of present stuff that you can probably read in a book or get off a video on YouTube, but to sort of give you in a very short time some important sort of clues and hints about how to go about managing psychiatric illness at a community level and in dealing with acute mental illness in the casualty. Um, yeah, just give me 1 second, please. Yeah. So coming to community-based psychiatry, what should be the focus? What should you guys who are in primary care and closest to patients in the community be focusing on? This is what we generally recommend, that your focus be on what we psychiatrists call common mental disorders, that is depression and anxiety disorders. And sometimes tobacco use disorders are also sort of put into that category. And the reason we recommend that you guys sort of focus on this is because these disorders are highly prevalent in the community. So these figures are from the National Mental Health Survey. That was a huge study that was undertaken by NIMANS that estimated the current prevalence of depression and anxiety. At depression was about 2.68%. And anxiety disorders at the time of the survey was 2.94%. When you look at period prevalence rates, they go up to around between 4 and 5%. So this translates to a huge sort of actual number of adults who have these disorders. And prevalence is associated with a lot of suffering, is associated with a lot of disability in patients having these conditions. And these are more common in women. We'll come back to the significance of this a little later. So not only are they prevalent, they are disabling conditions, and they account for about 1/3 of patients who come to primary care for help. So for example, if patients have come for whatever reason to see you in your primary care clinic, about 1/3 of them, studies from India show, are likely to have depression or anxiety, or sometimes combinations of depression and anxiety. The other big issue with depression and anxiety is what we psychiatrists refer to as the treatment gap. That is, patients, the proportion of patients who are either not on any treatment for their conditions or who are on sort of inadequate treatments for their conditions. And the treatment gap for depression and anxiety disorders are huge. So it's estimated at around 80-85% for these conditions, common mental disorders, right? Not only that, patients often receive irrational treatments. So there's literature on this from India, and I'm sure for anyone who's been in primary care for a significant period of time will be able to relate to this, that very often patients who have these conditions receive treatments like multivitamin infusions, uh, they receive pain killers, they receive steroids, they are prescribed sleeping pills very often and often get hooked onto these. So these are the problems that uh, that these patients encounter when they seek help. So now the main issue with these problems in terms of providing care to them is that of identification. So like we said earlier, missed diagnosis and misdiagnosis are huge problems. Either the diagnosis is not picked up at all, in which case they receive no treatment, or they receive no a wrong diagnosis and receive irrational treatments. And here is where there is a role for screening for these conditions. So there are various screening tools that are freely available online. So for depression, we generally use the PHQ-9, that is the Patient Health Questionnaire 9, which is a questionnaire that takes about 10 minutes to administer. What it does is it basically presents as questions to the patient the 9 DSM criteria for depression, and they rate on the scale um, based on a Likert scale, a Likert type rating, and a score of 10 or more is generally considered a screen positive for depression. What we use for anxiety disorders is called the Generalized Anxiety Disorder Scale. This is a 7-item questionnaire. And these two questionnaires can be used, they were designed to sort of be scored by the patient. But in our settings, what we find is patients are often unfamiliar with sitting with a questionnaire as you would in some Western settings before you meet the doctor and ticking off. So you can actually administer these yourselves. If you have a very, very busy sort of OPD, what is recommended is that you use shorter forms of these questionnaires. So there are 2-item questionnaires, say for example, available, the GAD2, the PHQ-9, PHQ-2, that can be actually administered. But I would recommend that the best way to do it is to actually slip these questions into your regular sort of conversation and interaction that you're having with the patient. So this calls for actually becoming a little comfortable with the idea of asking questions about, the patient's mood or the patient's ability to enjoy hobbies that they would earlier. So these are some things that we're not, familiar with. We're not generally trained to do during our MBBS training. But it becomes important, and with sort of practice, and you begin to get comfortable asking these questions, you will begin to identify, patients who have these kind of difficulties. So being able to ask, say, for example, so how would you generally describe your mood in the last 2 weeks? A simple question that takes not more than a few seconds can actually help you to pick up depression. Or asking, how have you been in terms of enjoying your hobbies in the last, say, a month. A simple question like that can help you to identify depression. Again, most of you I see are probably going to be in sort of primary care clinics and family medicine practices, say for example, or antenatal care clinics. So what is recommended is to implement these sort of screening procedures in certain care delivery platforms. What is generally recommended is in, say, antenatal clinics, or you have an NCD clinic, the rates of depression and anxiety in any sort of chronic disease, are much higher than what we see in the general population. And this is an important sort of avenue for you to explore in terms of screening for depression and anxiety. Of course, HIV clinics, we know. TB clinics, we also know that the rates of depression and anxiety are much higher than the general population in these patient populations who you are likely to encounter in your settings. Coming to why it is relevant for you to screen at least your own patients. So not we're not talking about uh, getting out into the community to perform some type of screening, but at least beginning with your own patients in the groups that I talked about in the previous slide, is because they affect outcomes of those diseases. So say for example, you're looking at diabetes or hypertension. Very often referrals to a general hospital psychiatry unit, like the one I practice in, are from physicians who are saying, hey, look, I have sort of optimized medication for hypertension. This patient appears to be anxious and the BP is just not coming under control. Or the same with sugars. So these are actually clues to and indicators to, that there may be a mental health concern here in a given patient. So if you're beginning to see multiple unexplained physical symptoms, could indicate a diagnosis of depression or anxiety. If you see, for example, like I was just saying, uncontrolled sugars or BP even after drug optimization, that's another sort of indicator. Very often we also see poor adherence to treatment regimens for these chronic medical conditions. So we get referrals sometimes for patients who don't who repeatedly sort of come back to their doctors saying that we are not taking the medication as prescribed. And this leaves the doctors very often frustrated and pulling their hair out to sort of get the patient to take their medication. But once we explore and when they are referred to us, we often see that there is a mental health concern there that's at play. So very often patients will tell us, like, what's the point in taking medication? If they're depressed, they're very often hopeless or pessimistic, or they see no point in taking the medication and getting better. So it could be something as simple as that. But like I was saying, the importance to improving outcomes in your own patients, medical outcomes in your own patients, and improving their quality of life and limiting disability is definitely a reason you should screen, at least select patient populations for depression and anxiety. So I can't emphasize this enough. Yeah. Coming very, very briefly to the management, of course, now SSRIs are the first line of management for depression and anxiety. A very important concept here in the use of SSRI medications is what constitutes an adequate trial of the medication. So these medicines need to be tried at an adequate dose for adequate duration, right? So if I'm using escitalopram, I need to give at least 10 milligrams for a period of 4 to 6 weeks before we say that it's not working, right? A short course of benzodiazepines, preferably clonazepam because it's longer acting, also helps to alleviate symptoms in the time that the SSRI takes to kick in. A word of caution here is you need to be monitoring the patient closely when you give them benzodiazepines, because especially if you're prescribing this to elderly, the risk of fall is significant. But patients can also become dependent on these medications if they're prescribed for more than 4 to 6 weeks. So you need to educate the patient about the use of these medications. Good old tricyclic antidepressants are also, an option. If SSRIs are not available, say for example, or cost is really sort of a big concern. Although SSRIs nowadays are not too expensive. So apart from pharmacological management, sleep hygiene, exercise, deep breathing are sort of non-pharmacological ways in which you can help the patient get better. Coming to indications for referral, so the patient has suicidal ideation, is clearly expressing ways in which they want to end their life, or has a history of a manic episode or psychotic symptoms, or fails 2 antidepressant trials, better to refer to a mental health professional. All right, coming to tobacco use disorders. So again, prevalence in primary care settings in India is estimated at almost 50% of smoked, smokeless, and 7% of both. This is a very useful guide that's freely available on the internet. It's the WHO manual, from which a lot of other manuals have also been developed. It provides a framework for assessment and counseling of patients who use tobacco, right? Again, the focus here in this is not to sort of establish a diagnosis of a tobacco use disorder, or to try and assess how severe that is, but it breaks it down into something very, very simple, uh, that allows you to sort of counsel the patient in a way that's likely to be helpful, right? So this is a broad framework and workflow for this of this document. So very often we don't ask, as is the case with common disorders, we don't ask for whether the patient is using tobacco, and that's if I can give you one message with regard to tobacco, it's this, that we should ask, all our patients, all our adult patients at least, about, and adolescent patients about tobacco use. So this is called the 5 A's and the 5 R's. The 5 A's are basically meant for patients who demonstrate that they are motivated enough to quit tobacco, and the 5 R's are a brief intervention module to improve the motivation of patients who are not yet ready to quit. Okay? So you'll see this in the toolkit of the WHO. The 5 A's basically are ask, advise, assess, assist, and arrange, right? You can keep something small on your desk to sort of remember these, because sometimes it's difficult. So basically, you ask all patients, you advise before you even sort of go on to assess their motivation. You advise all patients who respond saying yes, we use tobacco, in a clear, strong, and personalized manner about quitting tobacco. You then use 2 questions. Would you like to be a non-tobacco user, or would you like to quit tobacco? And do you think you have a chance of quitting tobacco successfully? And if the answer is yes to both, you go on to the next 2 steps of the 5 A's. That's assist, by setting a quit date, getting them to tell family, asking them to remove tobacco products, counseling them about withdrawal symptoms that they're likely to occur, and giving them sort of skills to cope with these withdrawal symptoms, and arranging for them to follow up, reviewing what progress they've made, and taking stock of how the things are going in terms of their quit attempt. So that's the 5 A's. The 5 R's are basically, if you find that the response to those two questions were not either undecided or no, then you begin to have a sort of back and forth conversation with them about, about what exactly they think about making a quit attempt, and try and elicit what are the barriers, what do they see, what do they anticipate as benefits of quitting, and then you work in a conversational style with them, using these steps to sort of improve their motivation. Right? It's all in the manual. You can sort of look at that. Right. I think I have about maybe 5 minutes more. So coming to acute mental illness in the casualty, so my idea here is not to take you through various mental disorders that present in casualty, but to give you some very, very broad pointers about what I think may be a useful information to you today to instill some confidence in handling psychiatric emergencies. So the great challenge, like one of my students was telling me, is that very often when an acutely behaviorally disturbed patient comes to our settings, we close the door on them, literally. So I think the confidence to manage them, it's not like we don't sort of know about how to manage them in terms of pharmacologically, or I don't think that's the biggest challenge. I think the biggest challenge is sort of knowing where we stand legally, and having the sort of behavioral skill sets, let us say, to be able to handle people with behavioral complaints who turn up in the casualty. So I'm going to focus on just two aspects here. So the first thing is an understanding of what we call verbal de-escalation. That's very often, not just with psychiatric patients, but even with patients in the casualty who are there for whatever reason, or family members in the casualty are there for whatever reason, we get into very difficult interactions with them, and things can get heated very fast. Tensions are running high as always in the casualty, because there are acutely sick patients there. But I put up only the sort of broad steps here. You can go back and read this document, this paper that looked at verbal de-escalation strategies, and it's written in very, very simple language, and it's extremely useful, because not often do we discuss these kind of things. So for example, simple things like what our body language should be like in interactions with not just family members, but also patients who are behaviorally disturbed. Respecting personal space, not being provocative either verbally or non-verbally, establishing verbal contact, being concise and clear in our communication, identifying their needs and validating their needs is something that we don't generally think of. Listening closely to what they are saying, agreeing to disagree, laying down the law and setting clear limits, offering choices and optimism, and debriefing patient and staff. These are the steps which you can again sort of go into more detail. The other thing is that I want to talk about in terms of acute care of behaviorally disturbed patients in the casualties, an understanding of the legal framework that exists. So the law is actually quite on our side. So for example, this is section 94, subsection 1 of the Mental Health Care Act, that actually the way it is written itself is a great support to any sort of effort that is made, not just in a primary care setting, but even in the community, to help patients with an acute psychiatric problem. So the only thing you have to be careful about here is to be able to establish that there is a clear need, that either death or irreversible harm or that the patient is likely to harm himself or others or destroy property, you have to be able to elicit that clearly and document it. So documenting who is the NR. By NR we mean nominated representative, which is a legal term, but enough to sort of note down who has brought the patient and what is their relationship with them, what is the severity of the behavioral problem. Again, we don't want to know what is the diagnosis, the exact diagnosis. That's not something you should worry about. You can make a provisional diagnosis, but documenting how difficult it was to get the patient to the emergency and how severe is the behavioral disturbance is more important. Again, the conditions that were met for emergency treatment, and document a plan and how do you want to refer the patient to an inpatient setting, and what is the sort of monitoring that you have instituted while you physically restrain or chemically restrain the patient. All right, with that, I think I am out of time. So thank you. Anjali, if we have maybe 5 minutes, do you want to take questions or?
So, Luke, what we'll do is if anybody has any questions, they can post it in the chat message. And if you can hang around for a bit, then you can answer them if there's anything. If not, I will send them to you and answer them. I mean, send your answers in to everybody, whoever asked any questions.
Sure, absolutely.
Yeah. Okay, thank you so much, Luke. That was extremely well articulated. We will move on to the next presentation, which is by Dr. Nirupama Shivakumar. She is a senior research fellow and has a degree in physiology and pediatrics. So this is definitely something that you should listen to. It's on growth monitoring. And if Nirupama is ready, she can start.
Hi, thanks, Anjali. I don't see the slide changing button, but yeah, if somebody can help, it'll be.
Just hold on a second. We'll give you control of it. If you still can't see it, then we'll do it.
Oh, I see it now. Yeah, thanks.
Okay, go ahead.
Hi, good morning all to all the doctors out there. So without much waiting, I'll start off. So I'll be talking about something that's very simple but very, very powerful tool for children who are in their growing phase. So I'll be basing my slides on why we should monitor growth. How do we monitor growth? And we are going to stick to under 5 children. What is growth faltering? And what causes growth faltering? And how do you approach a child who's faltering in growth or who's already faltered in growth? So we start with why should we monitor growth, right? So a child's growth, somatic growth we are talking about, has short and long-term consequences if there is faltering. And it affects mortality in the long run, morbidity, and again in the long run, risk of NCDs. So, and reproduction will also reduce. Child development, the cognition can be low, so school achievement will be affected. And by large, the economic for an adult who grows up who's had faltering growth can lead to reduction in health, increase in health expenses, and reduction in adult economic activity. So there is ample reasons out there and ample studies out there to emphasize on the need for monitoring growth. So how do we monitor growth? So in under 5 children, any of you in your facility, when you probably see the child for the first time or you are following up a child, ensure that you start a growth record for them, either at any given visit or at birth if you have a delivery facility. Determines the child's age. So it is completed weeks up to 3 months. And from 3 months to 12 months, you take the completed months. And once you do that, you'll identify the age and sex specific chart that is to be used. And before you plot it on this chart, you have to measure the child. So how do we measure the child? So I'm not sure, but I hope most of you in your facilities have access to equipment. So children who are not standing on their own are usually measured in a bassinet. Or if you don't have a bassinet in your facility, you can always do the mother-baby technique where you ask the mother to stand, give the baby to her if there is a tearing facility on your weighing scale, or else weigh the mother with the baby and without the baby and calculate the baby's weight. So head and mid upper arm circumference is usually measured with a tape that is non-stretchable. Ensure that it is standardized if you have these tailor tapes that are being used in the facility. Length is measured for any child who's less than 2 years, and they are usually measured supine. That is, the child is laid down on the infantometer, as you can see here. And height is measured after 2 years, where an stadiometer, which is the one here, is used for measuring the height. So these are the equipment used to measure growth. So as you see here, supine measurements are the most difficult. It will at least require three people. That is, at the head end, as you see, we'll usually ask the mother or the primary caregiver to hold the child's head. And we'll have two people who have to at least stabilize the child on the board and hold the foot, where you ensure that the whole heel is pressed against the footboard. And trust me, always the children are crying when they're put supine and measured on the board. And if you don't believe me on this, there you go. There's another child who's crying on the board. So there's always, children's very difficult to measure length. And that's why it's even more important to be accurate in your measurements, because you may go, mostly it's overestimated because the children are crying, they are pushing the board, and you may overestimate most of the times. Whereas height is fairly easy. Again, just as you see in the picture, there at minimum two people are required to measure the height. One to read off from the scale, and one to ensure that the child is standing in a straight line with their head touching the board, their shoulder blades touching the board, their buttocks touching the board, and their heel touching the board. So ensure all they're in the Frankfurt plane, they're standing straight, and they're touching the board when you're measuring. So once this is done, the next thing you need to know is where should I plot these, right? So for 0 to 5 years, our Ministry of Health and Family Welfare endorses the use of the WHO child growth standards. Now, this came out in 2006, and the measurements happened between 97 to 2003. And it was conducted in 6 countries. And India was one of the countries. So in India, it was in Nagpur, in somewhere near Delhi, that this was being, the measurements were being done. Around 200 children that were measured. Why are we saying this chart is probably the current best that we have? Because this chart is prescriptive in nature. It ensured that all these babies were exclusively breastfed, the mothers were non-smoking, and they had access to proper health care. So it's more of a prescriptive chart. This is how a child should grow. All right. So if you have preterm infants that you're following up or born in the facility, up to 40 weeks of post-menstrual age, we use what is called the Fenton chart. And now WHO has come out with their chart, which is kind of a extension of their WHO growth chart. It's called the Intergrowth 2021. So we can use those charts. After 40 weeks of post-menstrual age, you transition them to the normal WHO 2006 growth standards. And till 2 years, ensure you use the corrected age for preterm infants. So I hope you got this. So this is for children under 5. So there are Indian charts that is from the IAP 2015. That's the recent one. That is from 5 to 19. But if also there are, so these charts, they've incorporated the under 5 the WHO growth chart. So you see them, under 5 is from the WHO, and from 5 to 19 it's an Indian population only. But preferably for 0 to 5, it's best to use the WHO Child Growth Standards. And I'm really happy to tell you that St. John's is the nodal center for the ICMR growth reference standard. So now ICMR has commissioned something very similar to the WHO growth standards, and it's going to happen in 6 zones across the country. And St. John's is the nodal center for South Zone. So we've just started recruitment from this May 1st. So you will very soon, probably 5 years down the lane, you will have India-specific growth standards. Now, when I say growth standards, we are doing a longitudinal assessment of these children from 0 to 2 years. And beyond that, it is cross-sectional. 2 to 5 is cross-sectional. So be on the lookout for that next. So this is how the growth charts look. This is for weight for age for girls. I'm not going to the specifics of what. There are different. There are weight charts. There are height charts. There are weight for height charts. And there is BMI charts, head circumference charts, and also mid-upper arm circumference charts. So you see that there is a green line, that's the median line. And there's a red line here, that is low weight for age, that is at the -2 standard deviation or a z-score. And there's a black line here that is at -3, or a very low weight for age at -3 is standard deviation or z-score. So weight for age boys chart looks like this. And what you would want is that a child can start at any point at birth. But what you want them is to track parallelly along the line that they're starting at. So normal growth, general, it tracks to the z-score lines from the point where the child began. I hope this is clear. So ensure that there is tracking. They may be even starting at -2. Ensure that they track, and there is a possibility that they are catching up if there was intrauterine growth restriction. Okay, next we go on to what is growth faltering. So from our old textbooks, this was called failure to thrive. Now it's more appropriate to use the term growth faltering. What does it mean? It's fall by more than 1 standard deviation or 2 major centile lines downward. So WHO growth charts have both z-score or a standard deviation lines or centile lines. So if it is centile line, it's 2 major centiles. If it is a standard deviation line, it's more than 1 standard deviation line. And if it's poor weight gain, most commonly what we see when the inadequate nutrition sets in, it's an acute condition. When you start seeing that they are faltering in length or head circumference, it's mostly chronic. So and these children progress to have linear growth faltering. So stunting, which is defined as less than 2 standard deviations on the WHO growth chart. Underweight is less than 2 standard deviation on the weight for age growth chart. Moderate and severe acute malnutrition. Moderate is for less than 2 standard deviation on the weight for height growth chart, and severe acute malnutrition is less than 3 standard deviation on the weight for height growth chart. So what is stunting? It's low height, as you see here, low height for the same age of comparing to the other child. Underweight is low weight for age. So if you compare this child to its peers, this child has a lower weight for the same age. And wasting is, it has a low weight for the height. All right, so when do you start suspecting that there is growth faltering, right? So what we have to ensure is that we are serially marking their parameters on the appropriate chart, and you see here the child is tracking well from the point it has started, but you start seeing that there is stagnation at this level. So stagnation from 6, 7, 8, 9 months, right? So there is stagnation here. So that is one thing. Flat growth line. Okay, stagnated weight or no weight gain. Next is there's another example here of showing again of a flat growth line. Okay. So here we are seeing fall by 1 standard deviation. So what do I mean by that? So the child started off very nicely on the green line, and then the boy is going up and he starts faltering. He starts crossing over 1 standard deviation line and then stagnates. So that is, you will have to be very concerned when the child starts faltering. Okay, so now we've seen how do we monitor it, how do we track it, when do we identify that these children are either stagnating or faltering. So what causes growth faltering? There are again numerous reasons, but the key physiological mechanism is inadequate nutrition. And it's classified under organic when it's related to organ related diseases, non-organic, and mixed. So what is organic, right? So going by the organ, so cardiopulmonary, the child might have a congenital heart disease, pulmonary arterial hypertension, a tracheoesophageal fistula, asthma. So I'm not going to go through each one of them, but think of, there is either a increased demand of the nutrient that the child is not able to meet, or there is a, or the child is not eating adequately to meet the regular requirement. So one of these conditions, two main conditions are happening. So when, for example, in GI related issues, the child may be eating well, but because of malabsorption, the child is not able to assimilate the nutrients that the child is consuming. All right, so celiac disease, pancreatic disease, so anything that can disrupt the digestion and absorption mechanism. Likewise, you have neurological illnesses, you have endocrine disorders, hypopituitarism, hypothyroidism, and infections. And what we don't see, which is also a part of my PhD thesis, is something called environmental enteropathy. So this is subclinical. You don't see. So what researchers across the world have seen is, you are giving the child adequate nutrition, trying to ensure that they meet the requirement, but the child is still not growing. So suspect that they probably have enteropathy, and you might have to give it more than what that child requires for its age to ensure that the child bypasses this enteropathy and absorbs what it requires. Non-organic is most commonly seen. It's around 70% of the growth faltering cases, and it's mostly psychosocial, like environmental neglect, lack of food, stimulus, or deprivation. And mixed is a combination of organic and non-organic. So if you see this underlying causes here, so insufficient household food, like household food insecurity is insufficient food, inadequate maternal child care, insufficient health services, or an unhealthy environment. With these underlying causes can cause increase in morbidity or inadequate dietary intake and eventually lead to undernutrition or mortality in the child. So how do we approach growth faltering or faltered growth? It's like any other clinical condition. You gather relevant information, and here I'm not sure most of you would, in your busy schedules, would have the time to gather information on dietary intakes, but at least ask two questions if you can. How is the child feeding? Like whether there's a responsive feeding environment in the household. What do I mean by that? Is the child happy to feed or the child force feeding? One is that, and whether you can get some estimate of the socioeconomic status to understand whether the household food security is good or poor. So get those two information to see if the child is getting adequate nutrition. Birth details, birth weight is really important. Developmental details. So growth faltering is associated with developmental delays. So take a very good, if possible, a very good history, or just do a screening of their development. Current illnesses, even past illnesses, how many times did they, or do they frequently fall ill? And their family and social history is really important to see if there's domestic abuse or anything that's happening in the family that's psychosocially affecting the child. Physical examination, like we just went through, anthropometry, general signs and symptoms for looking at. Before we used to see a lot of kwashiorkor, you must have heard of marasmus, children in the community who have had an acute deprivation in their nutrition. And now most commonly we see marasmic children, that is children who are looking very thin. So look at other signs, look at white hot spots, look at signs for vitamin deficiencies, dysmorphism when it comes to you're suspecting a syndromic association to the poor growth, and any systemic examinations we are trying to look at do they have any cardiac issues, anything to do with their GI, ask for loose stools, ask for constipation, ask for vomiting episodes, and follow them with investigations when you've identified what likely the cause is. And management will involve nutritional intervention, medical if it is organic conditions, psychosocial support, which is very important. I don't know how much you commonly come across in a rural setting, whether the child is being tended to or parents are working, the child is not being tended to, they're just not being fed well. So psychosocial support is very important. Anganwadis play a very important role in rural settings, and maybe get an information of whether the child is being sent to Anganwadis, do they get their take-home ration, and follow up adequately. If the child is faltered already, or is being stagnated over a period of time, ensure more frequent follow-up. And if the child you feel is at risk, maybe you can have less frequent follow-up. So red flags for referral: when do you refer children to a higher tertiary centers? You identify a child with severe acute malnutrition who's with complications. So when I say with complications, they can have an acute respiratory illness, they can have diarrhea, any other related illness with severe acute malnutrition. And they are faltering despite your counseling and ensuring adequate nutritional intake. Children, they're faltered and they have developmental delay, or you're suspecting genetic, metabolic, or endocrine disorders. So these are the conditions where you'd probably think of referring them to higher centers for further investigation and management. I hope I've been clear. That's the end of my slide. So just as a rule of thumb for those who are busy and will not be able to plot growth charts, remember, when a neonate loses weight in the first 14 days, and hopefully by in 2 weeks, it should regain its birth weight and start tracking on its growth trajectory. By 3 to 4 months, an infant doubles its weight. By 1 year, it triples its weight. And by 2 years, the child weight is 4 times its birth weight. So again, I'm going to repeat this for those who are non-pediatricians. So from by 3 to 4 months, a baby doubles its birth weight. By 12 months, a baby triples its birth weight. And by 2 years, a baby weight is 4 times its birth weight. So as a rule of thumb, just remember this in case you were not able to track them on their growth charts. At least if they are not meeting these weight criteria, be cautious and go further on their history. So with that, I end my talk. And Anju, do I have time? Do you have time questions or?
No, we don't have time for questions, but I'll ask them to post it, and then I'll get back to you, and then you can answer the questions for them.
Sure.
Yeah.
Thank you.
Thank you so much.
Yeah.
That was excellent.
Thanks a lot.
Such a crucial but simple thing for pediatrics. So thank you so much, Nirupama.
Yeah, thank you.
We'll move on to the next presentation. It will be from Dr. Gaurav Gomez. He is a consultant PMR physician in Bangalore, and he'll be talking to you about acute stroke rehab in the community, what you can do. So Gaurav, take it away.
Yes. Good morning, everybody. Thank you, Dr. Anjali Olapalli, for inviting me for this. And I'm just hang on a bit. I'll just try to share my screen. Can you see my screen?
Yes, we can.
All right. Right. So early stroke or neurorehabilitation in the rural setting. Okay, I'm working currently in Bangalore Baptist Hospital. I'm from the batch of 2004, the same batch as Anjali. Introduction, I won't waste much time on this, but yeah, we all know that stroke is very common. People are affected. It affects not only the person, but the family. I won't go into numbers to bore anyone, because any stroke patient that comes to your OPD, you need to help them out. So that's it. What are the basic rehabilitation goals? Okay, prevent complications, pick up and manage complications that you can foresee, optimize independence, optimize the quality of life, maximize patient participation, and maximize their family's participation. Modify the activities of daily living as per your common sense and medical practices, and reintegrate them into the society. Preferably get them into a bit of sports, because that boosts their confidence and morale. So what are the activities of daily living? This is what any one of us has to go through on a day-to-day basis, which does not require much cognition, but is important and vital. So it's basically bathing, showering, dressing, toileting, transfers, and continence, which includes bladder and bowel, and feeding. So all these things need to be kept in mind when you're taking a history from a patient or trying to evaluate a patient who has neurological deficit. The deficit could be, depending on the area that is damaged. And so it's basically brain injury, which could be classified into traumatic or non-traumatic. Among the non-traumatic are the ones like stroke, MS, and so it comes under the umbrella term brain injury. And I would probably concentrate more on hemiplegia right now, because that is the most common presentation of a patient with stroke which comes to the rural setting. More severe strokes almost definitely end up in the tertiary care centers. So with any patient for that matter with a brain injury, you need to keep these things in mind and find out how the patient is managing all these things. Many a time, the patients actually come with a diaper or an indwelling catheter, and we know that these things are preferably avoided, because the diaper itself can cause more of a wet environment in the perineal area and cause ulceration, infections in females, higher chance of UTI. And indwelling catheters also have their own risks, like bleeding if there's a pull, infections, calculi. Okay, so we try to get them off the tubes. And in the initial setting, they come with NG tube or an indwelling catheter, maybe even with a tracheostomy. And if they are not able to, according to your evaluation, if you don't feel that they are ready to remove the tubes, then you need to help them to deal with the tubes, how to take care of it at home. Toileting, yeah. So not only the bladder, but even the bowel function needs to be taken into account. And feeding is very important. We've actually come across patients who the feeding makes the biggest difference. There was one tetraplegic patient recently who went to the ICU about 5 times because of his low immunity, and kept getting respiratory infections. And the moment we put in a PEG tube and fed him well, his immunity improved. He never went back to ICU. Actually, we had counseled them 2-3 times that the patient was not going to make it, but eventually he made it and came out of the hospital. So the core multidisciplinary team required for rehabilitation ideally would require a physiatrist, but a general medical officer in the rural setting is good. Nurse, a physiotherapist, community health worker or ASHA worker, and if possible, teleneurologist or remote consultation with PMR physician. Okay, so the initial assessment in the acute phase of stroke. So the funda is basically that you start off rehabilitation as soon as possible. Don't wait for the right time, because the earlier you come in, the more complications you can prevent, And also, the patients, the benefit the patient gains from your interventions are much more the sooner you start. So neurological assessment, I won't go into the scales because Dr. Francis will be covering that later on. But neurological assessment gives you a baseline to start off with. And on your follow-ups, you can check how much of improvement the patient has made. Functional assessment, what I mentioned about the ADLs and mobility, speech, cognition, all these things. And there is a scale called FIM, which is used for that. Imaging, if available, and screening for complications. Now, when a patient comes with NG tube, it may just be because the relatives are not, they just want convenience to give the tablets through that, which is also okay. However, you need to look at, is the voice sounding wet? And that could indicate, a lower cranial nerve palsy, including, and so the speech also might be affected, especially when you go down to the brainstem strokes or posterior circulation strokes. And in such cases, speech therapist also is ideal to help out with the patient. Skin integrity, because many patients who do not have, obviously many of the stroke patients do not have enough bed mobility. And if you keep a patient in one position for more than 2 hours, there is a chance, or there would be tissue death rather. So if you press your finger, you can see it at the back on your nail that you get the capillaries close up. And if you keep that position, you knock off the capillaries for 2 hours, that area would die. So similarly, in a patient who's lying continuously, this is what happens, and that's how pressure sores develop. So make sure that the patient, is very important, turns within 2 hours, within every 2 hours. And if that's not possible, I mean, it needs to be done even if you put in an air mattress or a water mattress. Okay, that's skin integrity. It's actually seen patients dying because of pressure sores also. Nutritional and hydration status, vitals. In the acute phase, that's 1 to 7, the goal is to prevent complications, stabilize the patient, and initiate early rehab. Positioning and passive range of motion to prevent contractures, because many of them come with spasticity. And because of spasticity, the wrist is in flexion, fingers are in flexion, elbow might be in flexion, and shoulder is usually in adduction. And that position causes, if it's there for a long time, can cause the muscles to physically shorten because of the spasticity. And once it physically shortens because of fibrosis, you cannot stretch them out later on. Okay, the earlier intervention, in fact, in the West, they start giving Botox at the earliest sign of spasticity. But in our setting, I would suggest stretching would be a great way to go ahead. Make sure that the muscles are stretched. And what we usually give is, when resting, if the fingers and the wrist is flexed, we give them a pan resting hand splint. That is available online on Amazon also. But if that is not possible in the rural setting, you could actually use plaster of Paris and fashion a splint, which could help them to stretch it out and tie it out with a dupatta or something, or bandage or crepe bandage. So that's positioning. And ankle is another point which can cause contractures very commonly. So the ankle needs to be in as much of dorsiflexion, or at least in neutral position when the patient is lying down, because when they lie down with spasticity and the ankle is by nature falls down, then the gastrosoleus contracts or gets contracted. Oral care to prevent aspirations, we advise patients to get suction apparatus if they do not have enough of adequate swallowing capacity. And you actually get pedal machines for swallowing, or even these small things which the relatives can use with one canister to suck in, indirectly do the suctioning. Swallowing assessment, feeding tube. DVT prophylaxis. In the rural setting, I would suggest probably just doing ankle pumping would be sufficient if medication is not available. Blood pressure and glucose control to prevent or to help in recovery because of the penumbra, which Dr. Francis will be talking about, the penumbra area, which is in a 50-50 phase, and some of it can recover if you take care of the milieu adequately. Family education is very important, because the more they participate, the higher the success of the patient. Subacute phase, restore function and promote function. Physiotherapy like gait training, balance, strengthening. All these things need to be kept in mind depending on the area of stroke. So if they have a posterior cerebellar stroke, they would tend to come with ataxia. If they have hemiplegia, then in fact they come with weakness of the knees, and they cannot stand because of that. So we give them a knee brace. We call them knee gaiters, but knee it basically locks the knee. So you can get an immobilizer, knee immobilizer, and lock the knee in the rural setting to help the patient stand. And once after standing comes balance. So standing balance, then we start with walking. The important thing to note is that the potential of patients. So generally people think that any hemiplegia, once the patient gets hemiplegia stroke, they are confined to bed for the rest of their life. It's not true. In fact, most hemiplegics have the potential to walk using these braces, or what we call orthosis, the medical term, and walking aids. So the other side, you need to give them a tripod or a cane, or auxiliary crutch if you require a little more support, or elbow crutches. Occupational therapy deals with the day-to-day activities, feeding, grooming, dressing, all these things. And you can actually use things like built-up spoons. So in a spoon, you could actually you could take a tennis ball, make a hole, and use that as a conduit to fix in different gadgets. So you can fix in a spoon in that. They can easily hold it because it's much larger to hold. Or you could just use cloth and make the build up the handle. So you could add in toothbrush, shaving blade, okay, in that same tennis ball. Speech and language therapy. Speech and language. So if I've come, I mean, there are cases where, especially the most scariest is the locked-in syndrome, which is because of a pontine infarct. Okay, bilateral pontine infarct, where the patient is absolutely cognitively normal, like you and me, but they are not able to move at all. They're not able to talk. They're not able to move their upper limb, no movement except for some amount of eye movement. And therefore, in such cases, you need to help them out using communication charts. Some of them might have a bit of head movement. So we've tried out even using laser pointers on a cap to try to point out letters and spell out words. In fact, there are these one gadget called the E-Trans, and that helps patients using eye gaze to communicate with their relatives. And after a while, they get so good at it that if they spell out the first few letters, the relative is able to gauge what they're trying to say and fill out a sentence. In fact, one of these locked-in patients has written books, okay, because the relatives have been so helpful for them, or they have participated as much and they haven't given up. Home-based programs and prevent complications again. So phase 3, more than 3 months, goal is community integration and long-term support. Continue the exercises at home, because even though the brain matter that has been damaged will not recover, the area around it can take some function, and they can have functional improvement. Not the neurons will not improve, but functionally the patient can improve. Vocational rehab, again, try to reintegrate them into society. Health education on prevention, because each patient who has a stroke has a much higher risk of getting a subsequent stroke again. Social support and peer group support is good, because they feel like there are other people who have the same issue, and builds up confidence. It reduces the chances of depression. We've seen that depression is and aphasias tend to be the biggest hurdles for patients to participate in therapy. So a social group would help there. And periodic follow-up using either a mobile or a telemedicine support. Now, coming to the complications that we need to prevent, neurological, basically seizures, ICP. If you find a deterioration in the patient's cognition, you need to first do the basic, like, GRBS, electrolytes, those are the common things. If that is not, if those are normal, then it might be something to do with the brain. You might have to repeat a CT scan to get a picture, because many of the patients might have, hydrocephalus or a new stroke that is developed. Musculoskeletal contractures are mentioned. Respiratory pneumonia is very common, especially in patients who have dysphagia. DVT, pulmonary embolism in the acute phase mostly. Pressure ulcers can come at any time. Also more in the acute and subacute phase. Therefore, positioning is very important. In fact, patients who are sitting require to be, tilted to either side or brought forward to relieve the pressure on the butts every half an hour. Okay. Psychological support, nutritional support. Okay, those are the basic complications. Now, this is just some pictographical representations for you all to remember the complications. Okay, so we have the brain there. He's got some muscles, so the musculoskeletal issues, and the heart, cardiovascular, respiratory. This is common. This is what you saw in the start. So this is Thanos having a claw hand. So contractures, muscular spasticity. Tongue is out. That is aphasia, and drooling. That represents swallowing issues. On the bed. Okay, so that is bed sores. Nutrition, the food over there on the side. And all these pipes represent your piping of the body. Basically, DVT and urinary independence or urinary complications to prevent. Okay. These is holding a cane also. So these things need to be kept in mind. This is just a way for you all to remember, because pictures are much easier to remember than all these letters which are there. Okay, fine. So what I just want to bring to your attention some of the CT scan findings. And what we see here is a CT scan of the brain. Looks symmetrical, looks fine, but it's not, because this is diffuse cerebral edema. You can't see the sulci out here, and these the ventricles are chinked. Okay, so this is cerebral edema, diffuse cerebral edema, and that can happen with brain injury, especially with diffuse axonal injury. This is what a normal CT scan of a brain looks like. When there's a stroke, that is a capsuloganglionic infarct, maybe have turned into a hemorrhage, hemorrhagic transformation. That's a tumor on one side. If there is edema and the sulci are not visible, and if there is a midline shift, which is significant, okay, you can see this side you can't see the sulci. Here you can see a bit of sulci. Then the ideal thing would be to do a craniectomy, which is done by a neurosurgeon, so that the brain matter can come outward, because the skull is a closed space, and if you do not give the brain enough room to breathe, more tissue dies. The patient deteriorates much faster. There's a chance of coning, and the recovery also becomes suboptimal. And subsequently, this can happen, which is called the syndrome of Trephine, where the atmospheric pressure itself pushes the brain back. In such cases, we ask them to do a cranioplasty again. This is what hydrocephalus looks like, and for that there is EVD placed, and this is what the EVD looks like. But this is after the EVD placed, there is still hydrocephalus. That also needs to be kept in mind, that EVD does not mean that the hydrocephalus is treated. You need to check it again, and this is over treatment of the hydrocephalus, where it's overdrained. Okay, rural specific adaptations. ASHA workers can be roped in. Telemedicine is a very good method to keep in touch and help out with the patient, including tertiary care telemedicine. Low-cost devices, walking aids, readily available. You can toilet adaptations. Family engagement is very important. Mobile health apps also available. You can actually get these communication charts on the mobile or in a tablet form, and patient can actually, either if they have some movement, but they have aphasia but they can comprehend, they can actually tap the buttons on the screen. Government initiatives, there are CRCs and DDRCs, district rehabilitation centers, which is at the district level. We have about 7 to 10 in Karnataka right now, and smaller outreach centers. And they have almost the full spectrum. They have a physiotherapist, occupational therapist, speech therapist, and they provide various aids and orthosis, the mobility aids, like even power, these tricycles, tri-wheelers, wheelchairs, free to the patient. And therefore, if you can locate them in your district, in your rural area, then the closest one, you can actually utilize them to get the services to the patient. So this is the DDRC. It is the goal is to give best rehabilitation that is possible in the rural setting. So early identification and intervention therapy services is available. I think I've explained all that to you. And timely referral to a higher center. This is another pictographical representation to remember basic stuff that needs to be done for patients. So you have a dumbbell on the side for physiotherapy. These boots or this for, okay, fine. These boots are for the orthosis. Walking cane for mobility aid, may require a cane or a walker depending on their issue. This is wheels for, wheelchair mobility and all. And from our side, injections. So for spasticity, you can either give tablets. I would suggest you could start off with baclofen. If a patient is having significant spasticity, 5 milligram BD, and then increase it slowly. And in certain situations, if the spasticity is too bad, we go for Botox injections. We use ultrasound guidance to inject the right muscle. And if a patient cannot afford Botox, which is very expensive, we give nerve blocks under ultrasound guidance to the motor branches so that the spasticity reduces, prevention of contracture, and improve functioning of the patient. And yeah, there's an alphabet chart at the back. And so that is for the communication part, just to remember the communication part. Yeah, I think that should be good. Low cost, you can use various things like a plaster of Paris that I mentioned, resistance training, resistance bands, and smartphone-based analysis, smartphone-based apps for telecommunication, Zoom, etc. Have I finished 15 minutes?
Yeah, you have.
Oh, I think I must have gone over. No, okay, fine.
No, that's okay. No worries. Thank you, Dr. Gaurav. That was excellent. And also, thanks for giving feasible solutions that they can tailor to their needs in the community, and for making it very creative. We will share your slides, so anybody who wants to go back and look at it can easily do that. Yeah. Thank you so much.
Thank you.
We will quickly move on to the next one. This is by Dr. Steve Paul, who's a senior consultant geriatric physician. And he will be talking to you about the atypical presentations of the geriatric population. If Dr. Steve is there. Is Dr. Steve online? You can post any questions that you have on the in the chat, and we can get Dr. Gaurav to answer it, or any of the speakers throughout the CME.
Hello?
Yeah, we can hear you, Steve.
Okay. I guess a lot has been talked about, a lot of things, and probably all are formed. Let's quickly. Do I have control of the slides, Dr. Prithvi?
Give me 1 minute. I'm giving you control.
So we'll start with a case, a short discussion on how we can go ahead and see how this case will play out.
You have control now. Could you check, please?
Yeah. So let's take the example of a 74-year-old man admitted with fever at onset, followed by dysuria since 10 days, inability to walk since 5 days, known case of diabetes, hypertension, COPD, and mild renal failure. On examination, he is oriented. Blood pressure is 130 by 80. Neurological examination shows his motor power is about 4/5, bilateral upper and lower limbs, meaning his power is fairly okay. Reflexes are slightly diminished. In the knee jerk and ankle jerk, they're almost lost. Sensory findings are minimal. Examination of the abdomen is unremarkable, and respiratory system is also rather fine. At this point, diagnosis. What could be the diagnosis? Any guesses? A common diagnosis that we may want to consider is a peripheral neuropathy, or even a myelopathy. Often, this actually was a case that started off when I was in St. John's a couple of years ago. So, what is the weak link in this picture? We'll come back to that case later. But what is this weak link here? You can see this bullock cart with a man sitting on a bullock cart, heavily laden bullock cart. Which of this is likely to crack? It could be the wheels. It could be that the load falls off. It could be that the legs of the bull breaks, or it could be that the whole cart itself breaks. So the weakest link is often the mode of presentation when it comes to older persons. Non-specific symptoms often are very common. This could be altered mental status, weight loss, fatigue, falls, and dizziness may be the earliest or only manifestations in this age group. Let's discuss a little on geriatric syndromes. Geriatric syndromes are often described as a final common pathway to modes of presentation. The ones that we commonly know of are dementia, delirium, depression, constipation, pressure ulcers, incontinence, frailty, sleep problems, vision and hearing problems, and fall or fear of falls itself. What Bernard Isaacs once coined as geriatric giants are immobility, instability, incontinence, intellectual impairment, and iatrogenic. This term has now largely been changed by John Morley, who I happened to meet at Australia where I was trained earlier. He has now modified this and called this as a modern geriatric syndrome, which includes what we now know as frailty, sarcopenia, osteoporosis also. Geriatric syndrome. So if you look at the definition of syndrome, a syndrome is a group of symptoms which consistently occur together, or a condition characterized by a set of associated symptoms. We know of Down syndrome, we know of Marfan syndrome. There are particular factors that come into play to produce a unique set of symptoms. This is what definition of a syndrome is. So geriatric syndrome is used to capture those clinical conditions in older persons that do not fit into discrete disease categories. So they are defined as multifactorial health conditions that occur when accumulated effects of impairments in multiple systems render an older person vulnerable to situational challenges. While the definition may seem a little tricky, the fact remains that a patient comes with a problem elsewhere and develops with a different set of symptoms, as you have patients who come in with confusion following a urinary tract infection, because all systems are in a situation where they are kind of compromising and managing to pull along. So the weakest link there may be the urinary system, although the infection may be somewhere else, which will result in an incontinence. The chief complaint here does not represent the specific pathological condition. As I said, example of urinary infection may precipitate delirium. A patient with a new form delirium with no fever altogether, he would just come with a new onset delirium, and the diagnosis should be thought of as a urinary infection if other causes aren't identified. These occur because of altered neural function in the form of cognitive and behavioral changes that permit the diagnosis of delirium. This is important because it determines many functional outcomes too. So what's so special about geriatric syndromes? Multiple risk factors or organ systems are often involved. The diagnostic strategies to identify can sometimes be ineffective, burdensome, dangerous, and costly. An example would be a patient comes with delirium. If you know delirium could be a sign of an infection elsewhere, it would prevent the need from multiple MRIs, lumbar puncture analysis, etc. But still, the therapeutic management of these clinical manifestations can be helpful. Even if you do not have a firm diagnosis, treating delirium has its own positive outcomes. And why do these people present so atypically? One, because of multiple comorbid conditions. Multiple comorbid conditions could manifest symptoms in a different way. If a patient has got a heart condition, he may precipitate as a failure. He could precipitate as a heart failure when actually the problem is elsewhere. Two, age-related physiological changes. An example of which is febrile response to infection is often not seen. So these patients may not have fever, although there is an infection. Cognitive impairment may prevent the patient from providing an accurate history, and often the family is also unaware. Often now, in the present generation, we find older persons living alone, so an adequate history may not be something that's easy to come by. If you look at the geriatric medicine models, we know the standard internal medicine model. You try and find a group of symptoms and signs, group them together into a cluster, try and find the pattern that will explain this, and this one disease that explains all of these would be the most likely diagnosis. This is what we call Occam's razor. Find a set of symptoms, define the pattern, find a unique single diagnosis that explains all this. Whereas in geriatrics, it's a little tricky and hence difficult. One of the models is a synergistic morbidity model where 1 + 2 is equal to 7, meaning a multiple accumulation of multiple events combined with social and environmental problems, each insufficient to impact on a person's performance, but together take a toll in a way much beyond what is expected. Let's take the example of this older person. Let's call him Mr. Keshav. So Mr. Keshav has dementia. He wanders around. He has this habit of hoarding items. And his caretaker is an equally older lady who has severe osteoarthritis of the knees. Now, because of his habit of hoarding items, wandering around, his dementia has suddenly gotten for the worse. And she is now moving around extra than earlier that she used to. Because her osteoarthritic knees have started to pain more, she now starts to take stronger medicines, let's say something like a tramadol for pain relief. And due to excessive caregiver burnout, she resorts to making poorer meals and even takes a couple of 2 drinks of alcohol. Now she has a fall, and this becomes an emergency situation. So this is an example where we come to see the patient only at this point. The patient has landed with a fall. If we go to the story behind, we come to know there's a whole lot story to begin with. The misattribution model. It is A, not B. The problem is attributed to one cause, where in actuality it is due to another cause. Let's take another example. A 76-year-old lady admitted for an acute coronary syndrome undergoes a stenting procedure in a hospital, in a major hospital, and hence is hospitalized for a couple of days, or let's say a couple of weeks. She's also diabetic hypertensive, and they report to you a week later after discharge that she's severely fatigued early morning and often noted to be sweating. The blood sugars are fairly okay. The blood pressure is also 112/64, fairly okay. These are her list of medicines, which includes diuretics, aspirin, statin, dapagliflozin, glimepiride, metformin, pantoprazole, metoprolol. Any guesses what's happening here? Any guesses? So when this happened, when this was brought to the cardiologist, right, there is a polypharmacy going on, but the early morning fatigue and post-discharge, when brought to the attention of her cardiologist, suspects she's continuing to have ongoing ischemia and prescribes a vasodilator. Now she has a fall, following which an ambulance is rushed and she's readmitted to the hospital. So in actuality, look closely at the readings. Fasting sugars of 86 itself is quite low. In a patient post-hospital decline, likely not eating very well, it is very likely that she is developing early morning hypoglycemia. Also, her blood pressure readings. We know the blood pressure readings are supine readings of 112/64. Either hypoglycemia or hypotension induced by the vasodilators could have precipitated the fall. More likely, that's the diagnosis than an acute cardiac event. So these factors have to be borne in mind when a medication is being prescribed. The causal chain model. A, B, C together, a continual series of troublesome health problems in a previously independent older person can gradually wear them out to a point of seeming no return. Mrs. P, poor balance secondary to peripheral neuropathy, complains of insomnia and starts taking a benzodiazepine. Now she develops a fall after taking the benzodiazepine and develops a hip fracture. Hip fracture necessarily puts her on a less mobile status and she becomes bedridden. Now being in a bedridden state, now she develops a bed sore. And then the family now decides it may be better that she's in a nursing home or an aged care facility. So how continual series of events suddenly lead to functional decline, leading to a poor quality of life and poor rehab outcomes. The unmasking event. A sudden stressful external event, such as an acute injury, medical problem, or loss of a caregiver, can reveal a previously unrecognized and hidden medical problem. Let's take the example of Mrs. and Mr. Smith, a happy couple, aged couple, living by themselves, all seemingly well from the outset. Now, Mrs. Smith passes away suddenly, and Mr. Smith is all alone. Now, there is a difficulty in paying bills. They notice that he's having problems in paying the bills, in taking medicines by himself. And he doesn't seem to be able to manage his home very well. He's burning pots in the kitchen, mixing up his medicines. He doesn't seem to be very depressed, appears to be cheerful. So what's happening here? Most likely, he probably had dementia, or he had a mild dementia to begin with. This was being compromised or compensated by his wife, who was acting as a peripheral brain. An examination by his physician now reveals that he is suffering from Alzheimer's, which was hitherto undiagnosed and not seen, not diagnosed and not treated. So these are some of the unmasking or various models of which older persons present. But there are the typical geriatric syndromic presentations also. Non-specific clinical presentation they come in. One of the most common ones which I've mentioned to earlier was delirium. This may be often the only indicator of a serious underlying disease. Disorientation, fluctuation in the sensorium, nonsensical verbalization, increased somnolency, and hyperactivity are also parts of delirium. Now we know hyperactive delirium, as we very commonly have seen in our medicine wards when alcohol withdrawal state. But what is often missed is the hypoactive delirium, where the older person just stares at you, not answering any question. If you are lucky enough to go by and ask him, can you tell me where you are? He would probably say, I'm at home. So that's the hypoactive delirium. The history or risk factors for delirium are old age itself, severe illness, dementia, physical frailty, infection, dehydration, visual impairment, sensory hearing impairment, polypharmacy, immobility, using physical restraints, a catheter, tying up the hands, intercurrent illness, dehydration, constipation, social isolation. All these put a person at risk of delirium. You should always rule out infection as a primary possibility and check your respiratory and other systems well. Metabolic disorders, cardiology evaluation, and CNS involvement also need to be considered. The common thought is hyponatremia, but hyponatremia often is not the only factor. Hospital itself is a risk factor. Prolonged ICU stay, post-surgical patients, use of restraints, catheterization, and sleep deprivation also contribute to delirium. Weight loss. Undernutrition is indicated by unintentional weight loss of more than 5% within a year. 3 days of isolation, 3 days of hospitalization is sufficient to bring down the weight to about 3% lower than what it was earlier. The causes of undernourishment are social, psychological, medical. Social is, of course, poverty, functional impairment, isolation, poor knowledge of nutrition, isolation, depression. Psychological, bereavement, paranoia. Medical causes are dementia, pulmonary cardiac diseases, inability to take food very well, medications itself, and endocrine causes. So when you encounter a person with undernourishment or a possible weight loss, instead of jumping to a diagnosis of malignancy, first and foremost is to assess, is the patient taking adequate diet? If yes, then we need to evaluate. If no, check why. Is it physiological? Look for any underlying disease. Is it a medication effect? Check his screen for his cognition by using the MMSE. Check his routine investigation and find out if it's a pathology that's causing this. Fatigue. This is the most dangerous of all the symptoms. Whenever a patient comes to me saying it's only fatigue, the problems could be n number of problems. Excessive daytime fatigue is never a normal process of aging. Chronic fatigue, physiological causes could be hematological causes, therapy related. Congestive heart failure can present. Renal or liver disease can present. Endocrine disease can present. Severe COPD, sleep disorders, medications. And I need to stress on the medications part again. Psychiatric illnesses, depression. When you evaluate a patient with fatigue, take a careful history. Look for red flag symptoms. Do a systems review, because the symptom they describe may not be pertaining to the actual problem. Do a screening, including the labs and medication review. Dizziness. 30% of older persons complain with this symptom. Almost every few patients in a day, I think at least a few patients come with vertigo or dizziness as a primary complaint. The fact, again, the cause may not be restricted to a single system. It could be cardiovascular, vestibular, neurologic, Psychological, this leads to fear of falling and hence complete immobilization. So they stop walking. Always rule out pre-synco. Always, always, always check for blood pressure, sitting and standing. 1 or 3 minutes preferably after standing. This is very important. Look for orthostatic hypotension. See if your history matches what is in favor of orthostatic hypotension or a vasovagal attack. Sometimes a sudden fall while performing an activity could indicate an arrhythmia that's going on, and a patient may require an ECG or a Holter monitor. This is different from disequilibrium, where the patient says, no, I don't feel a blackout. What I feel is I feel unsteady on my feet. The problem isn't here. The problem is below. That's a sense of disequilibrium. This is usually constant and occurs while standing or in motion. The causes are often vestibular. It could be sensory, proprioceptive, or cerebellar. Slide isn't moving. Prithvi, the slide isn't moving.
I'll just help you 1 minute. I'll just stop sharing and present again. Sorry. Some technical glitch.
Yeah, I think go to the next slide.
Yeah.
Yeah. Can we move to the next slide?
Sorry, it's not actually going on PowerPoint.
Can I present?
Yeah, please. Sorry about that. I've tried again. It's not moving beyond 33 slides. Third.
No, I'm able to. Is my screen being visible?
Yes, it is.
Is it visible now?
Yes, it is.
Something wrong again. Let me try. Yeah. Is it visible now?
Yes.
Okay. So non-specific dizziness. Sometimes patients do not tell you that it's rotating or I feel like it's a blackout. They don't come with typical textbook descriptions. So it's very difficult to describe. They start out by telling, I feel like I'm on a boat. I just feel giddy, dizzy. It becomes really challenging to try and find out what is the symptom. But nevertheless, you should screen for any infection. You should screen for vestibular disorders and also consider hyperventilation or even headache sometimes, or even fatigue. They would use dizziness for everything. So take a detailed history. If possible, do a Dix-Hallpike maneuver. Do an audiometry, blood pressure measurements, again, supine and standing. And check screening with lab parameters to look for any other possibilities of to explain your symptoms. Falls. Now, this is something we all are very carefully aware of, and most orthopedicians, most of these patients land into the orthopedic unit. What's important and what is often missed is why has a patient fallen? So whenever you take a fall history, you need to ask questions like, where was the fall? What was the fall? How did the fall happen? What was the patient doing at this time of fall? Was he walking to the bathroom, or getting up from a sitting position, or did it just happen because he fell off the bed? All patients over 65 years should be screened for a history of falling in the past year. You would be surprised how many patients come forth saying it, yes, I fell last week. The cause of the falls are cardiac disease, neurological disease, sensory impairment, often iatrogenic. Medications, physical restraints can precipitate fall. Primary gait impairments. When you take a history, as I mentioned, ask also for premonitory symptoms. Did you feel dizzy before the fall? Did you feel your vision blurring before the fall? All these are helpful in evaluating whether it's a presyncopal attack. Review of medications. Often you'd find these patients are on multiple medicines, including sleep medicines. Non-prescription medicines need to be looked into. These all can precipitate a fall. Which is why a comprehensive geriatric assessment is very important. It helps you find out all the problems that the patient has had, all the medications he takes, and all the problems he actually suffers from but isn't communicating. Do a gait and balance evaluation, which is a simple test asking the patient to stand side by side and turn around. I often ask my patients to walk a few steps and turn around and come back. A test called as a timed up and go test. Neurological evaluation needs no reiteration. A weakness and decreased proprioception, rigidity, tremors, stoop, gait, all are important in determining his postural stability. MR imaging, ENMG, musculoskeletal imaging, cardiovascular evaluation also is important. Look for valvular lesions, carotid bruit, arrhythmia, and an ECG echo is vital. Fever. This is rare though, but it's a warning sign for a potentially life-threatening infection. It may be even absent in infected older adults. Older patients may have an average lower temperature. Any older individual with a temperature of greater than 99 should be considered as elevated. So common diseases and the presenting symptoms. This is the gist of atypical presentations. And if you look at GERD, gastroesophageal reflux disease, in an adult, the symptoms commonly are postprandial burning or reflux symptoms. Whereas in an older person, it may be just dysphagia, hoarseness, or even cough. Peptic ulcer disease manifests as an epigastric abdominal pain, whereas in an older adult, it will just come as a bleeding. Rheumatoid arthritis is an indolent course in adults, whereas in older persons, it could come acutely with fever. MI, we all know, comes as chest pain, whereas in older adults, it may just come as delirium, may just present as a heart failure. Pneumonia in younger individuals with fever, cough. In older individuals, delirium and just tachypnea. Not even cough, if you noted. UTI manifests as dysuria and fever. In an older person, just delirium and nausea. To conclude, atypical is typical in the elderly, and awareness of these signs is required for an early diagnosis. I'm happy to take any questions if there are.
Thank you, Dr. Steve. That was truly an eye-opener, and I'm sure they'll benefit from you us sharing the slides for them to see later. If there are any questions, they can post it on the chat thing, and then we'll get back to them, and I'll coordinate with you to help them answer. Help them get their questions answered. Yeah. Thank you so much. That was excellent. We'll move on to the next one by Dr. Deepak Varghese, who is a community medicine doctor but has extensive experience in palliative care and has worked with Pallium India. So he will talk to you about palliative care in rural India. Deepak, you're online? We'll share the slides for you now.
Yeah, sharing them. One moment.
Hello, am I audible?
Yeah, you're audible.
Yes.
We'll give you control of the presentation now, and then you can start.
Okay.
You
okay,
have
let's
your
start. Yeah. Okay. So yeah, this right. So this my talk is on palliative care in rural India, and first question that I have for many people here is, is palliative care really, there, in rural hospitals, we have a lot of challenges. We are short on equipment, we're short on manpower, we have a lot of limitations. But in that, can we actually provide palliative care to our patients, right? So is it a luxury or a priority in rural low cost general practice settings? And for this, I think the first thing that we need to do is we need to look at the definition of palliative care. And I think the one word that I want you to take away from this definition, I know it's a long definition, is quality of life, right? Because ultimately, a lot of what we do is with regard to quality of life, and not only for the patients, but also for their families. And uh, this can involve taking care of physical symptoms, but it can also involve taking care of things beyond that, which is why we often require a multidisciplinary approach, right? So this is one of the figures that is often quoted in palliative care settings. So when somebody has a chronic, so palliative care is usually done in not just in cancer, because we have an impression that it's always cancer, but it's something that's applicable in most chronic diseases. That includes cancer, but it also includes things like COPD, chronic liver disease, chronic kidney disease. They're not conditions where you typically associate with palliative care, but the fact is that for somebody with long-standing COPD or long-standing kidney disease, how likely are you that this patient is going to get a transplant? It's not. We would love to see the day when transplant becomes the an easy option to get. But the fact is, most of our patients end up, with long disease courses, with you know, without necessarily getting the symptomatic relief that they get. So one thing that a lot of people talk about is palliative care is sometimes seen as defeat, but that's not really what we want. So the idea is that early on in the course of illness, if we actually integrate palliative care early, we can actually see that palliative care, the role of palliative care gradually increases in the disease course, but it's not something that should be brought about only in the end. So, so if you look at this figure, it's actually a nice analogy where they use this umbrella. So we bring in the umbrella of palliative care early on in the disease course, not because they need palliative care early on in the disease course, but because when they choose that they want it, we can actually, it's actually available, right? So, the patient can choose when they want to, and it's not that palliative care is in direct competition with curative medicine. Both of them can occur simultaneously. So you can, but it just means the palliative care there is a bigger focus on symptom alleviation compared to the rest of medicine, right? So a lot of this sounds very theoretical, something that you can dream about. But actually, if you look at it, palliative care is predominantly thought about in general practice. Specialist palliative care, especially in the Indian context, is very limited, is very rare. It's not something that everybody has access to, right? So I think a lot of actual palliative care delivery has to be done by general practitioners and by clinicians, by other clinicians, right? So if we need to be actually looking at palliative care, I think we need to, because there's no point in me telling you a lot of fancy theory about palliative care, but let's go back to looking at what general practice is all about, right? So we go back to the most basic book that we are introduced to in second year of medicine, the Hutchison's or MacLeod's clinical medicine. And if you look at page 1, right at the beginning, it talks about from making the cure of the disease more grievous and the endurance of the same. So this is not, specialist medicine. It is something that should be carried throughout general practice and throughout all of medicine. Because if we look at why a patient really comes to the doctor, so any patient who reaches the OPD has reached the OPD after a long struggle. They've waited at home for some time. But finally they're there because there is a crisis, and they think that making that travel to the hospital is worth it. And this is because of the illness. This is because of the pain they're having or the symptom they're having, not necessarily because of the disease. Because the patient does not always understand all the nitty-gritties of the disease, but what they understand is that they're having pain and that they're having breathlessness. So unless we actually address this, it's difficult for us actually to convince the patient to, for the rest of it. So what I really want to talk about today is a very brief consultation framework, which is something that all of us are exposed to. But I just want to, show you a few ways that you can integrate a few concepts into your normal day-to-day OPD practice. So if you look at our normal OPD practice, most of us are trained in filling out a case sheet, right? All of our medical training in undergrad is about filling out a case sheet. But can we really directly take that case sheet filling approach into our interactions with our patients? Not necessarily. So this is predominantly an OPD based framework, and it covers some of the things that were even covered in the previous. So I think in the one of the first, Dr. Luke talked to us about the importance of screening about depression. We talked about screening for ADL. So how do we actually integrate this into our actual day-to-day practice? So I'm just talking about a very small framework when you can see the questions on screen, so I'm not going to deal with it. But I'm talking about some of the things that we don't routinely do, but we should probably start doing and will probably help us to do. Okay. So this is a little bit in the management part, and the last one that you saw was in the. So I'll go through this. So I'm not really. So in terms of management, explaining the diagnosis to the patient, and okay, so I'll go through this one by one. So introductions, how many of us actually introduce ourselves to the patient? This is very rare. But this is something that I started doing fairly lately. And believe me, every time you introduce yourself to the patient, I've always gotten a smile in return, because it's very rare that you always assume that the patient knows who you are, but it's not going to take you time also. It's going to take you maybe 10 seconds, right? But the patient is going to give you a lot of privileged information. And when you do that, I think the first basic common courtesy is to introduce yourself, right? And another thing that it is said that within 11 seconds the patient is always interrupted. But I would actually give you guys the challenge to actually not interrupt your patient in the first 30 seconds. Okay, it says golden minute, but I would say golden, because when the patient comes to you, they've thought of a lot of things that they want to tell you, but we often cut them off and then they forget what they came to tell you. And what happens is you lose out on valuable diagnostic information. This is not specific to palliative care, but it is specific to a lot of good medicine in general, because the dictum in medicine is listen to the patient, they're telling you the diagnosis. A lot of times when we're sitting in OPD, we kind of look at chronic disease and then we say, it's just repeat regular medication, repeat regular medication, continue same treatment. That's a lot of our patients. A lot of patients who we have with diabetes, it's always continue. But like was pointed out early, I think a general framework for this is checking, is the patient compliant to pharmacological advice? Are they compliant to non-pharmacological advice? Are we seeing complications of the medications? Are we seeing complications of the disease? And screening for depression and other annual exams, right? So this is something that I want to make sure, because if we look at complications of the medication, that avoids all the geriatric issues that doctor that we were listening about before, that can be avoided. If we screen for depression routinely, it doesn't take a lot to screen for depression routinely. Like Dr. Luke was telling us, you can use PHQ-2. How was your mood in the last 2 weeks? And do you now find things, do you not find things that that were previously enjoyable are not now enjoyable? 2 questions, give screen for depression. So I'm not saying take long psychiatric history. All I'm saying is screen for depression. Check your compliance to medications, because medications that are sitting on the cupboard are not going to make any difference to the patient's life. You have to check whether they've actually taken it. Just because it's written in your chart or it's, the patient has bought the medication does not mean the patient has taken the medication. Right? So check for all of these things. Approach to disability. This has been covered extensively in the last one, but for any patient who has a chronic disability, we should be screening for disability for most of these things. And to understand whether this has been covered, but I just want to remind you that you have to screen for disability in most patients who have come to you with a chronic disease. And look, do a general screen for symptoms that can be distressing. Is there pain? Is there breathlessness? Is there vomiting? Is there constipation? Constipation actually is a very underrated symptom, because The most common cause of delirium in the ICU, for example, is constipation. But nobody asks for it, so nobody sees it. And you're seeing a lot of problems, but actually the underlying cause may actually be something as simple as constipation. It's not very difficult to treat, but it doesn't get picked up because we don't ask for it, right? But just to rule out red flags, again, you have to know for each condition what are the relevant red flags. It could be things like loss of weight loss, fever, night sweats, signs of abuse, blurring of vision, sudden loss of weight. All of these things are conditions that you need to know. So, for example, for psychiatric illnesses, suicidal ideation is a red flag. So there are red flags specific to each condition. So the reason I'm taking this is so that you kind of know what to ask, right? And then how is this making an impact on the patient's life, or what does the patient expect from this? Okay, so I want to take a minute because this is where it all plugs into palliative care, because what is the patient's goal of care? That is one thing that you need to identify. What matters to the patient, right? We can, as physicians, it is up to us to decide which line of treatment is the best, or all of those things we can actually think about. But ultimately, the line of treatment we choose has to align with what is the patient's goal of care, right? What is important for the patient? And this is something that you can't necessarily ask the patient, but at the end of it, you have to really understand what does the patient want from this management. For example, in something as simple as diabetes, right? The goal of care is to prevent complications. Why do you want to prevent complications? Because once complications set in, then you're looking at a lot of other problems and then the patient's quality of life is going to decrease, right? So your management of diabetes is not necessarily looking at your HbA1c values or your PTBS values or your fasting values. Getting that number under check is not the primary goal of diabetes management. It is to prevent the complication, right? So you have to think about how is this impacting the patient's life and impacting the family's life. And if you can track this, this can actually guide all of your uh, interactions after that. The problem is we don't necessarily ask this always, right? And when you talk about psychosocial history, you have to remember the patient's environment, and it can be a cause of disease and it can also be the effect of disease. So when we talk about things like family dynamics, environment, all of these things is important, because unless we identify them as cause of disease and effect of disease, we're really not going to be making much headway in spite of all the pharmacology in the world, right? So this is just some 5 questions that you can ask to kind of get a full psychosocial history. It's not going to take time. It's not even going to take a single minute, but understanding who does the patient live with, what does the patient do for a living, did the patient come driving is something that is important, because he may end up in an accident. You prescribe a sedating medication in the patient who's a driver by profession, he's going to end up in a big problem, right? So substance use, is there smoking, is there alcohol? This is actually a good place to actually do the screening you know that uh, that we talked about earlier. Does the patient smoke? Does he want? Is he liable? I mean, is he willing to quit at this point of time? What is the role of diet? What is the role of exercise? It's not going to take a long time to ask these questions, but we don't ask these questions because sometimes we blame it to a lack of time, but it really doesn't take a lot of time for us to look at, right? Now, when coming to management, uh, at this point, we have gotten a sense of what the patient's goal of care is and what matters to the patient. Address these things when you make your management plan. Right? This is, I think, the most important thing when it comes from a palliative care point of view or a palliative care point of view. What is the patient's concern? What are their expectations? Is the patient in any serious pain? Right? So when you talk about pain, I'm talking about the same old things that we learned in first year, second year of MBBS, where we talk about site, onset, character, radiation, associated factors, relieving factors, and scoring of pain. We know how to do these things, but we don't do them, right? So this is just a gentle reminder that, when a patient, the pain is where the patient says it pain, right? There's really nothing more than that. If you look at the new ISP definition of pain, it talks about uh, pain due to an organic cause or a perceived cause. So, even somebody who has, like, say, functional abdominal pain still has pain, right? So we need to address it. If it's a functional cause, we will never know it's a functional cause unless we have taken a psychosocial history, right? So the reason why I took you through all of those other things of history taking is because unless we identify a functional cause of pain, we're not going to address that functional cause, right? So take pain seriously, take constipation seriously. They're not very difficult to treat, but if we identify them, we can treat them, right? So this is just, I don't want to get into the how to manage morphine and things of that sort, but the this is what the WHO ladder that we've all seen. But at the bottom, you have things like paracetamol and NSAIDs. At the middle, you have weak opioids like tramadol and codeine. And at the top, you have strong opioids like morphine and fentanyl. I don't know how many of you have access to morphine and you can use it, but most of you will have the NSAIDs and tramadol. Tramadol, the reason why it exists at the moderate pain is because because it's more accessible. Yeah, it's not the greatest painkiller in the world if you ask palliative care physician, but it exists because it's slightly more accessible than morphine, right? So you have to know how to use them, but these are what these is, and it's not that you always need to start at the bottom. A patient with severe pain can be managed with morphine, but I don't know how many of you have access to morphine. So coming to that, suppose you have a patient with severe pain, where do you refer? Why do you refer? Okay. The idea behind all of that previous thing, what I told you, is so that you can identify patients that need specialist care. Once you identify them, where do we refer them, right? Okay. So what I want to introduce quickly is Pallium India, the organization that I used to work with. It's an NGO where they have telehealth consulting for doctors. This is not telehealth for patients. I mean, patients also can contribute them, but they have consultation for physicians, right? And so you can actually give this number a call and discuss the case with them. They can actually guide you as to what might be the most appropriate way of managing this pain or the symptom, right? So that is something that you have to keep in mind. The website is palimindia.org, and actually, if you look at the website, they have a telemedicine button that's there right at the bottom. It's there right on the front page. You can't miss it. You can take down the number if you want. It will be there in the slides. And the link on my slides is clickable, so you can just go there, right? So that's one thing. The other thing is if you want to physically refer the patient, they also have a referral directory state-wise. So and if you look at it, it gives you details of who the physician is in that center and whether morphine is available or not. And it gives you a quick overview of whether they have OP services, IP services, and morphine availability. So you can actually pick up your phone and call the palliative care center nearest to you, and you can actually have a chat with them. I would encourage you to do this. Okay, and if you want to actually stock, essential narcotic drugs like morphine, at your center, there's actually guidelines to do this as well on the website. You can actually go through this, and there's a form that you can fill and things like that. And if you need help with that, you can actually reach out to Pallium India. I think they will be on the telehealth guideline, and they will probably be happy to help you with that also. Uh, when you talk about the one thing that you need is also for the ability to dispense morphine is training. So Pallium India also offers training that is there on palliumindia.org/training. And they have a lot of courses that's available, foundational courses, 6-week courses, including full fellowships. So you can actually look at that and have a look at those things also. Another really useful resource actually comes from another organization, Uppressure, because for every state, they have actually compiled what are the government schemes available. So this helps you a little bit in terms of social factors. Yeah. So, for example, a patient cannot pay for it. So for healthcare schemes in Karnataka, for example, it has state-wise, and you can actually look at it. It tells you what are the benefits offered by that scheme, by that program, what is the eligibility for the program, what are the documents you need to submit to the government, all of these things, and other helpful resources that are there. So they've compiled it state by state, and so you can actually look at your respective state, and you can actually reach out to the organizations that are there. Abdashak is another great resource that is available, because ultimately, and that's actually, I think, my last slide. So this idea behind this was to give you, so just to quickly recap, it's taking a good history is the crucial thing, because I didn't go too much into the management, and that is deliberate, because a lot of palliative care is just identification that there is a problem, and it doesn't take more than 7 to 10 minutes to take that history. So I think an OP consultation deserves 7 minutes. I don't think, I know that patient numbers are huge, but a patient who comes to you even with a repeat prescription, simply writing continuous same treatment, I think sometimes it doesn't do justice to that. And if you can identify the psychosocial problems, if you can identify the complications, if you can screen for depression for every single patient, I think it goes a long way to integrating into a lot of these talks that are there, right? So that's my time, and I hope I didn't overshoot. So
No,
that's
thank you so much, Deepak. I think palliative care is important for everybody, and also the distinction of it being for all chronic diseases. And especially thank you so much for sharing all the resources available through Pallium India, which everybody can access. So since we're sending the slides, people can click on it through there. Otherwise, I'm sure they can access the website and access it from there. So thank you very much, and we'll move on to the next presentation. If there are any questions for Deepak, again, please post them in the chat, and we can get them answered for you. So the next presentation is by Dr. Aditi Pinto, who is an orthopedician with a specialization in pediatric orthopedics. So if Aditi is ready, we can start the next one.
Yeah, thanks, Anjali. So I think pediatric ortho, the most important thing to know about it is that we're not treating smaller adults. They have a different bone biology, and which makes it treating children a little differently. Most of us during our medical school internship, as well as through post graduation, you think of them as smaller adults, but the treatment has to be a little tailor-made for children, because they have a very different bone biology. So some of the pearls while treating children with bone issues, either be it trauma or infections, some salient points are different. For example, the musculoskeletal examination is based on point tenderness. Most of the times the children will not, they'll be very apprehensive. New doctor, new setup. No one likes coming to the hospital, let alone children. So you may or may not get an adequate history from the parents, especially if the child has fallen elsewhere in school. The children do not come home and tell the parents everything, because they're scared that they'll get scolded by the parents. Another thing is, so one main thing is that they come a little later on to the hospital. Another thing is, that they treat everything related to trauma. So most of the conditions may not also be trauma related. They'll associate all of them with a previous history of trauma, just because it's how they want to tell their parents. Next point I would like to emphasize on, if you can splint by immobilizing with a slab, you can almost treat anything temporarily within your means before you want to refer it to a higher center. Most often children are very flexible. Their cartilage, their ligaments are highly flexible, so they will rarely have sprains. If a child has come with a painful limp or a painful hand, likely to be a fracture. Sprains are very uncommon. In a child, usually fever and redness and a warm hot joint is infection. Could also be tumor, but could mimic as infection, but most commonly to think of infection first. And the last point, always worry about the hip. It is routinely commonly missed, because the child usually will present with referred pain to the knee. So if a child comes with pain around the knee or around the thigh, even referring to the knee or proximal leg, always examine the hip as well. So we'll just cover about 4 or 5 of the most common conditions. One of them is clubfoot. So you probably would have a delivery. Most of the centers have a big gynae load. So you'll have a child post-delivery. You'll probably see the child is having what we call CTV clubfoot. It could be positional, or it could be the entire spectrum of CTV. It causes the foot to be turned inwards and downwards, and if it's not treated, it can be quite debilitating for the child. It's a very, very straightforward treatment. At that stage, when you get a child who's delivered post delivery, you realize a child has CTV. Nothing to worry. Counseling of the parents is very important, that it's completely curable. Treatment to be started as soon as possible after the child gets discharged, when the child is breastfeeding well. If the child is a preterm requiring ICU care, it can wait. I mean, the club foot can wait. Completely treat the child initially for his acute conditions. Once the child is healthy and gets discharged, a week after that, they can come and visit an orthopedic surgeon. Till then, what is to be done is stretching exercises as demonstrated in the picture here. Since the foot is otherwise turned inwards and downwards, the stretching maneuver is to push the foot upwards and outwards. So one hand on the inner aspect of the foot to push it out, and the hand just below the ankle or the talus. This is the point where the doctor's right thumb is. So you show this maneuver to the parents, that the child, the mother has to be stretching out the foot after every feed until about 5 to 10 days, till the child is healthy and comfortable. And once the child is comfortable with feeds and everything's okay, you can call them back. If it's just plain positional CTV, stretching is enough. If after 1 week we realize that yes, it is the whole spectrum we're dealing with, you can refer, any orthopedic surgeon can start casting. It's prudent to not attempt to do it, because usually overzealous casting causes a different rocker bottom reverse deformity, and that is challenging to treat. So serial stretching followed by a review with the pediatric or with the orthopedician, who can start casting. Once the casting is done, it will be managed with just CTV shoes or a foot brace. So at that stage, it can be dealt with. Coming to another common condition, very, very commonly seen, is the supracondylar humerus fractures, most common elbow fractures in children. Important because it's one of the common fractures to present with a vascular compromise. As you can see in the X-ray here, this spike of the proximal humerus is what goes and impinges on the brachial artery. So when you get a child with a swelling and deformity over the elbow, first thing would be to do is check for the pulse. If the pulse is there, not a big worry. You can probably immobilize the hand, and if it is undisplaced. So this is an X-ray of a fairly severe one, where you have to send for close reduction and manipulation plus minus surgery. If it is undisplaced and the pulse is well felt, you can just apply the slab in about 80 to 90 degrees of flexion and treat the child with that. However, if the fracture is this displaced, it can come with vascular compromise. Now, the most common reason for getting a pulseless hand is the brachial artery being kinked. So as soon as the pulse is not felt, you could give a gentle traction like I'm showing in the next slide. So this is how the child will come. There might be a bruise or ecchymotic patch in the anterior aspect of the cubital fossa. It's an indirect marker that the brachial artery has been impaled between the fracture fragments. So this is the image of how, with a slight traction with the elbow in about 40 to 50 degrees of flexion, and the doctor's left hand is milking the fragment down. So you gently milk the fragment down, give a little bit of traction, and try to restore the deformity. There's a big chance you might get the pulse back. Even if you don't, it's probably still in spasm. But if the child's hand is warm, you still have time, can immobilize him in a slab like this and refer the child immediately. If the child, his hand is cold, clammy, then it is prudent to directly refer it to a center that has a vascular surgeon on call. So the surgical management is very essential and urgent when there's an absent radial pulse, or there's an impaired perfusion, signs and symptoms of impaired perfusion. And in that case, it's best to refer immediately, just immobilizing for the pain relief, so the child the hand can be salvaged if the hand is cold and clammy. If it's warm and just you feel that the artery could be in spasm, do try this maneuver by pushing this fragment down with a gentle traction so the brachial artery gets freed from the ends. Try this maneuver and then refer if the pulse is not felt. Another common condition is the pediatric forearm fractures. This is where it's very different from the adult forearm fractures, because most of the adult forearm, or in fact all of the adult forearm fractures, we require surgery. But children have a very good remodeling potential. And if you get a child like this, you can immobilize him on a above elbow slab, get serial x-rays, and as long as the alignment is being maintained, the fracture will unite without any worries. If it's an adult patient, it would require surgery irrespective of the alignment. So why, coming to like I mentioned about the hip, why do we need to worry so much about the hip and urgently? One is it has a very unique blood supply, which makes it vulnerable to damage in case the blood supply is disrupted. Blood supply could be disrupted due to a fracture where the arteries would be sheared, could be secondary to an infection, a septic arthritis, which will ruin the head. So once because of its precarious blood supply, the head gets damaged. Once damaged, it's unlikely to recover. And the child will have, have a disability throughout his age, throughout his adolescent period, until probably the only option would be to reconstruct it, if not a hip replacement once he's older. When it goes bad, it gets really bad, leading to disability because of the blood supply. Early diagnosis for several disorders like DDH, septic hips, SCIFI can really change the entire course of treatment, because most or all of these conditions have a treatment, and it can go back. We can reverse the changes up to a point. That's why, like I would like to emphasize, about 80% of our children who come with hip pathology come with referred pain to the knee, owing to the nerve supply being the same. So always examine the hip. We missed some as well in the past. Coming to the surgical emergencies, 2 or 3 of the cases, one is septic arthritis. So musculoskeletal infection in children can be life-threatening, and like I said, lead to a lot of disability. If it's already presents with systemic illness and sepsis, they go bad very quickly. So examination of the extremities along with a full systemic assessment, just to know, because a lot of the times septic arthritis in children is seeding of an infection, probably of another source. So you want to examine the child as a complete, see if there's any potential sources of infection which has led to it to the septic arthritis in a nearby joint. So you want to do the essential hematological investigations, your blood counts, your CRP, blood cultures, radiographs of the affected joint, and if your center has an ultrasound, would be very advisable. Very straightforward surgical drainage. Sorry, I think, yeah, the treatment would be empirical intravenous antibiotics should be started as soon as possible. It's fairly simple to go in for a blind joint aspiration and try to aspirate some of the fluid. If you can wait until you send the culture, you are higher likely to get a positive culture there. And as soon as the child is stable, makes sense to go in for a surgical drainage as soon as possible. Best would be within the first 24 hours of diagnosis. Septic joints can be potentially debilitating for the child overall as well. Compartment syndrome is another surgical emergency, both in children as well as adults. It could occur after a fracture, but after the fracture is when everybody is vigilant. Post-surgery, post-burns, or if the child has been treated with a cast outside or treated with native treatment. We get a couple of children. This was a picture of a child who we got after being treated with native tight bandaging at his village for a supracondylar fracture. So he had a tight compartment. The moment we examined him, his hands were cold and clammy. His with reduced sensations. Now, the classic symptoms of pain out of proportion and pain with passive stretch may not be there present in children. Pain out of proportion will be there, but most of the children will be crying all the time because of the pain. Anxiety and increased need of analgesia in children are the 2 A's we have for, in addition to the 6 P's, regular P's for compartment syndrome. So the child will be very, very anxious. Usually after the child is immobilized for an injury, the child should be comfortable. But if the child has increased anxiety or there's an increased requirement of analgesia, that is when it's an earlier marker for compartment syndrome, and it requires a fasciotomy with the slightest suspicion of compartment syndrome. If not, please send somewhere where it can be done by a general surgeon anywhere. So fasciotomy is limb saving for compartment syndrome in children and in all age groups. So when do you refer patients expeditiously? Like I said, one is there's any signs and symptoms of a septic joint, especially septic hip, but all septic joints, if we do not have means of treatment at our center to be sent. Supracondylar fracture with a pulseless hand, and if the hand is cold and clammy, or the hand is white, showing low perfusion. Open fracture open fracture with an open degloving injury with an ongoing bleed is when you want to send them quickly. And if you're suspecting compartment syndrome, if you can, your center has ability to treat for fasciotomy, go ahead and do it. Don't wait to send. If not, send as soon as possible. Most of the times, orthopedic conditions require serial follow-ups, a lot of x-rays, and close monitoring, because children for other routine fractures can be treated with simple conservative management. So it's prudent to treat immediately and then send for a follow-up maybe in the due course of time, so that we can monitor for any deformities or changes that happen in future. Yeah, these are some of our happy children, some not so happy. Yeah, that's all. I'm happy to take up questions on chat.
Aditi, thank you so much, especially for all the very critical conditions, but you've managed to explain all of them with such clarity. So thank you. And like she said, if you have any questions for her, please put it in the chat. We'll get them answered for you. We'll move on to the next presentation, which is now as you saw, Dr. Gaurav took the thing on the session on acute neuro rehab. So what happens before that? So this is Dr. Francis Joseph on acute stroke care in the community.
Hi, am I audible? Okay.
Francis,
so I'll begin.
You'll get control of the presentation.
Right. So I'll be speaking about acute stroke care, and as I understand, we're a little short on time. So I'll get through my slides quickly. All right. As we all know, strokes can be broadly classified into ischemic or hemorrhagic, and a bulk of the strokes that you deal with will be ischemic. And it's the ischemic ones that I'll be focusing more on in this presentation, right? So when you have a stroke, you will once you get imaging done, you'll see that there will be a core infarcted area, and around that there will be a reversibly dysfunctional tissue, and that's the tissue that you can salvage with early treatment. So you can image this penumbra using MRI or CT perfusion. Your goal is to start treatment as early as possible. The earlier you start treatment, the more of the penumbra you can salvage. The management at a tertiary acute stroke care setup is to either thrombolize the patient with alteplase if the patient presents early, and nowadays you can even send the patient for a mechanical thrombectomy up to 24 hours after symptom onset, based on CT perfusion and MRI findings. In the last 10 years, we've had a lot of landmark trials, the most famous ones being the Dawn and Diffuse trial, where they found that the subset patients who were likely to benefit from endovascular therapy included infarct core size of 25 cc's or less, and a penumbra at least 2 times more than the size of the core, with a relatively high NIHSS score of 10 or more. I'll come to that a little later. Right. So this is the advantage of getting an MRI done early. If you can get it done quickly, you will start seeing changes in the diffusion weighted imaging almost immediately, which will not happen obviously with a plain CT scan, where the hypodensity takes some time to set in. So that's the advantage of getting your imaging done early, and that's why all the guidelines say that you have to get an MRI or a stroke done or a CT done quickly. This is a CT perfusion scan, and on the right side you can see that the area highlighted in green is the penumbra. The area highlighted in red is the irreversibly damaged core. So the penumbra can be salvaged. So how do these patients present to you, right? So it's important for you to be able to distinguish between the patients who are presenting with bleeds and the ones that present with ischemic events. And unfortunately, all the classical symptoms that are described for intracranial bleeds, like vomiting, seizures, accelerated hypertension, meningismus, oculomotor palsy, thunderclap headache, none of these symptoms are reliable enough to go by, and therefore you need to get in your imaging done. And here's one reason why. Here you can see two different patients with the one on the left showing a right PCA infarct and the one on the right showing a right PCA bleed, and both PCA territory bleed, and both patients will present very similar symptoms. So unless you get an imaging done, it's impossible to tell which is which. So that's why the guidelines say that it is imperative to get an MRI or CT done quickly, and that's a level 1 indication, because you need to find the patients who are candidates for lysis or for thrombectomy as quickly as possible. So what can you do when you're sitting in a primary setup, in a primary care setup, or in a rural health facility? Should you be giving the patient aspirin? Well, the guidelines say that you don't need to give the patient aspirin immediately. In fact, you can wait 24 to 48 hours. It should be given, but you should probably wait a little while before giving it. You don't need to give it immediately, and aspirin is certainly not a substitute for thrombolysis or for thrombectomy. Should you give the patient statin? Well, all these patients do require statin, but that is a decision that should be taken as after consultation with various departments, because statins, while they do have benefits, they also come with a set of risks, and safety profile has to be determined before you give a patient statin. So you can probably hold off on that as well. Do you give a patient anticoagulant? If a patient comes to you in atrial fibrillation, you're tempted to give the patient, start the patient on heparin. But the guidelines again say that you can probably wait on that as well. Do you give the patient an anti-epileptic? The guidelines say no. They are unequivocal about that. Do you give the patient steroids? The guidelines again say absolutely not. Do you give the patient an antibiotic? The guidelines again say that there's no role for antibiotics, and there's no role even to put in a Foley's catheter, right? So what can you do? I think more important than what you can do is probably what you can't do, and that's why I started off with the contraindications. This is what you can probably do, and this is where you can start off. You can probably keep a list of the nearest stroke care centers with you, and you can probably liaison with these stroke care teams, get to know them and get to find out what their protocols are, and therefore you can sort of fast track patients whenever you receive stroke patients. So as soon as you get a patient with a stroke, you can notify them immediately. You can activate code stroke, because time is brain, and the longer you wait, the larger chance of the patient's penumbra being irreversibly damaged. So while you are in the process of referring this patient off, what can you do? You can ask, you can find out a little bit about the patient. You can find out about whether the age of the patient, the history, whether there's any history of trauma, young patients with trauma. It could be some dissection of an artery, for example. Is there any history of infection, tuberculosis, maybe meningoencephalitis causing vasculitic infarcts? It's important to know when the patient was last seen well, because the time from symptom onset determines whether you can lyse the patient or whether you can take the patient up for an endovascular procedure or not. And you can find out if the patient is on anticoagulants and if the patient is on antihypertensives. If they are, what are they? All of this is important for you to communicate with with the team you're referring the patient to. And it's also important for you to calculate the NIHSS score. And this is probably something you can keep a printout of at your clinic. You can sort of practice scoring your patients, because patients with low scores with very mild strokes probably won't benefit from thrombolysis, and patients with very, very high scores, like 25 or more, also may not. It's those in-between scores which are probably candidates for lysis or for thrombectomy. So it's always a good habit to calculate this score. It includes the level of consciousness, the orientation of the patient, the response to commands, the gaze, whether there are visual field defects, the facial movements, the motor functions of the arms and the legs, whether there's any ataxia, whether there's any sensory deficits, language deficits, and how the patient is articulating, and whether there is any inattention. Right. So next, you move on to an airway assessment. That's the A in the ABC. And you check whether the patient's airway is threatened. Is the GCS less than 8? Is the patient pooling secretions? Is the patient aspirating, which could indicate that there might be some bulbar involvement? You could do a simple chin lift and a jaw thrust and give the patient a little bit of oxygen in order for the patient to stop obstructing the airway. And if you have the facilities to intubate, and if you have a qualified anesthetist or an emergency medicine doctor, somebody who's familiar with intubating, and if it's a dire emergency, and if you feel like the patient needs to be intubated, and you've got the tools, you can go ahead and intubate and bag mask the patient till the tertiary care center. A good rule of thumb is to remember that if the patient can speak, then the airway is safe. And there's no role to give oxygen if it's not required. In fact, if you give oxygen unnecessarily, you might cause harm. So keep the SATs above 94. When you're shifting the patient, what do you do with the head position? Because traumatic brain injury, for example, patients need to be kept head up with at least a 30-degree head up position. But in stroke, it's a little different. There has been only one large trial called the head post trial, funnily enough, that found that the evidence to keep the patient head flat was not that great, although there have been several small studies that have shown that lying flat may improve cerebral perfusion and large vessel occlusions immediately after the stroke onset. Obviously, if the patient is vomiting, then you don't want to keep the patient lying flat. Otherwise, it might be a good idea to keep the patient flat. BP, now this is controversial because you don't know whether the patient has had a bleed or the patient has had an ischemic event. And if the patient has had a bleed, then you may want to reduce the BP faster. And if the patient has had an ischemic event, then you want to be a little more circumspect with the BP reduction, especially because these patients may be even having carotid artery stenosis and the perfusion may be compromised as it is. So you may need to keep the BP on the higher side for these patients. For stroke patients, generally, as a rule of thumb, you have to target a BP of around 185 by 110 because that is the threshold for thrombolysis. That's the cutoff for thrombolysis. And if you see a BP higher than that, then you can probably start the patient with low infusion. But you should remember that BP should not be lowered quickly, and your threshold to lower the BP should be just about 20% lower than the baseline. Obviously, if the patient is having a low BP, then you have to resuscitate. You have to start fluids, and it's always a good practice to measure BP in all 4 limbs. Right. Temperature. So this one's an easy one. If the patient is febrile, just give the patient paracetamol. Paracetamol is safe. does no harm. Is there any role for hypothermia? There isn't. All the studies so far have not conclusively said that hypothermia will be of any benefit. So normothermia is the rule of thumb. Blood sugar. Now here, this is crucial because hypoglycemia, neuroglycopenia can be detrimental. So you don't want that. So please treat with dextrose if required. And hyperglycemia is also not a good idea. It's not good for the patient because the patient won't respond well to thrombolysis, and B, the hemorrhagic transformation in especially large malignant infarcts can worsen with hyperglycemia. So target a blood sugar level of 140 to 180. And this is secondary. This is really if you have time and you're waiting for an ambulance to come, for example, you can probably get an ECG done, and you can send trop levels as well to save the tertiary center some time, and you can communicate all of this information to the stroke care unit once the patient is on his or her way. So this is my last slide. Essentially, it has been found that over the last decade or so, maintenance of things like stroke registers are important because the channel, the pipeline needs to be well maintained right from the time of presentation to the primary care center, right up to the time the patient reaches his destination of care. And any delay and any misstep along the way can prove detrimental to the patient's outcome. So it's important, I think, for all of us, wherever we practice, to maintain a stroke register and keep a track of the patient's details, including their presentation, their vitals, their scores, what time they were referred. And it's always nice to follow up these patients with our referral centers with regards to how they did after they presented to that hospital. Like I said, each and every step along the way is important in ensuring that the patient has a good outcome, and a lot of these patients are salvageable, provided we are diligent and we follow the guidelines well. Right. Thank you. Okay, Anjali, I think I'm done.
Hi, just one moment, Anjali.
Thanks, Francis, and thank you for rushing through your slides. That was now we'll have the last presentation before the panel discussion, which is by Dr. Maria Archana, who is also specialized in geriatrics, about how to deal with the dementia in the community. So if Archana is online, we can start. Again, if you have any questions for Francis, can you please put it in the chat and we'll get them answered for you.
Can you all hear me?
We can hear you.
Yeah, thanks. Hi, so today we'll talk about dementia in the community.
You will get control of the presentation now at the bottom.
Yeah, yes, got it. Okay, so why is dementia important to us? So according to the World Health Organization, about 55 million people globally are expected or currently with dementia, and this is expected to double by the year 2050. Now, as we all know, as our age increases, we are all at risk of developing dementia. Now, dementia is an umbrella term. It covers a lot of different diseases under them. And the most common one among them is Alzheimer's disease, with 60 to 70% of the cases of dementia being because of Alzheimer's. So other statistics say that 1 in 9 older adults above 65 years of age have dementia. And most of them live at home. So you will be seeing them maybe in clinics when they come for a follow-up, in the accident and emergency department, or when you go there for home visits. So early identification of dementia is important, basically because it improves the quality of life of the patient as well as improves the morbidity profile. So, dementia is a progressive neurological condition and it affects not just the memory, but also the judgment, the cognitive functioning, the reasoning, the independence of the patient is affected, and the patient may be unable to perform their activities of daily living, which include simple things like bathing, clothing, having a bath, toileting, dressing, etc. They have multiple needs, which would be another class in itself, and this requires regular assessment at the OPD or whenever you see them. And it is different from delirium and normal aging. Delirium is acute confusional state, and normal aging. So there are three components. One is memory loss secondary to normal aging. One is cognitive impairment, or the MCI, that we say mild cognitive impairment, and the third part is dementia. In normal aging, there is a little bit of memory loss, but it is not so extensive that the patient gets affected or their daily activities are affected. And it's as simple as I go to a room and I forget what I went in for. It happens even to you and me, and it can be when we are under stress. Okay, so in the normal aging, it is not progressive and it does not affect their activities of daily living. These are two important things that you need to know. In cognitive impairment, it starts affecting their daily activities. For example, they're cooking and they forget to put off the stove, or they forget to put an important ingredient while cooking, or they are on a regular path every day for a walk and then now they forget how to come back home, or they go to shop to buy 10 items and they come back with 2 items. Okay, so these are simple things. Or we have issues with transaction with money or with banking and things like that. Dementia is a far-fetched thing wherein the patient is completely dependent on somebody else for all their activities of daily living. So they are unable to eat by themselves, they cannot clothe themselves, they cannot bathe themselves, they cannot they do not remember the faces of their loved ones or the names of their loved ones and things like that. So when there is complete or most of their activities of daily living require assistance is when we call it dementia. Unfortunately, dementia is irreversible, but the symptoms can be managed to a certain extent. So dementia is an umbrella term, as I told you, and the most common cause is Alzheimer's disease. The other ones are vascular dementia, wherein the patient has impaired motor skills and there is judgment, and this is seen mostly in patients with diabetes and high blood pressure. There is frontotemporal dementia, which is seen in a younger age. Here, Alzheimer's vascular, we see it in patients after 60, 65 years. Frontotemporal dementia can start as early as 45 years, and it usually starts with personality changes and issues with language. In Lewy body dementia, here the patient can come in with hallucinations, impaired thinking, and motor activity. There are other types of dementia, like dementia with Parkinson's disease, HIV-associated dementias, and Creutzfeldt-Jakob disease. Now, Parkinson's disease is more of a motor disease. So the dementia comes in later. So the patient is very well aware if they have a memory issue. So why do I need to identify dementia and how do I do it? So this is usually first noticed by the family members or by the primary caregivers of the patient. It can be missed appointments or missed medications. As I already mentioned, there may be safety concerns like leaving the stove on, forgetting the way back home. They may misplace items. There may be altered judgment. Like for example, the person may give 500 rupees at the shop and forget to collect the change. They may have difficulty with writing, etc. So coming to the diagnosis, history is the most important. Without the history, we will not get anywhere. For example, history gives us where exactly the symptom started, how it started. Did it start with his activities of daily living, or did it start with his personality? So that gives us a differentiation of what type of dementia we are dealing with. I had one patient where the history was that he traveled to the US and he came back, and 2 days before leaving from the US, he started developing memory issues. And the first thing we did was, after assessment, we did a CT scan and it showed that he had a stroke. So that stroke was the reason why he was having memory issues. So our whole management per se will change when we know what the exact diagnosis is. So the tests that we also do are the cognitive assessment tests, which include the MMSE, the MOCA test, or the Montreal Cognitive Assessment, and the mini-cog. Now, MMSE and MOCA take about 15 minutes per patient when you're doing it in the OPD, and mini-cog can be done in like less than 5 minutes. I will come to that in a minute. Other than the regular blood test, the additional tests that you would do are B12, folate, the thyroid function tests, the liver function test, the urine routine and examination, and the calcium tests, because alteration in all of these can cause a little bit of memory impairment. Imaging is important, especially to rule out structural causes. Patients with Alzheimer's can have a CT scan which shows diffuse atrophy of the brain. Patients with vascular dementia can show chronic small vessel disease. Okay, there are certain specific changes that you can see in Parkinson's. So again, that helps us to localize and decide what type of dementia we're dealing with. Now, depression can cause something called pseudo dementia. So treatment of depression is very important, especially when you're thinking of a patient who is lonely, who has a very poor social support, or he's surrounded by people, but he is still, internally not happy with himself or with the people around him. Now, delirium, as I told you, is again acute confusional state. Now, the MOCA test that we do it when the patient is not delirious. Okay, that means, so first you ask them where they are they oriented to the time, place, person, do you know where, who's the people around you, and then go ahead. Now, vision and hearing are two important stimuli for the brain. So for a patient with dementia who has hearing loss, the dementia will progress faster. Okay, and for a patient with visual impairment, it's the same, it will progress faster. So correction of vision and hearing is important, and see that each patient that comes in is managed accordingly. So this is the mini cog, and we start with a 3-word registration. So you can choose any random 3 unrelated words, and you give them the words, ask them to repeat it. Now, for the step 1, the patient is not marked. Okay. Step 2 is when I ask them to draw a clock. The clock can be a circle. So there are specifications for this. Okay. The clock can be a circle or it can be a square. You write they are supposed to write the numbers inside from 1 to 12. See that they've written it correctly. Next thing is you look at the hour hand and the minute hand. The hour hand should be small, the minute hand should be larger, and you're supposed to have the time at 11:10. Okay, so 10 past 11 or 11:10. Now, if the patient is able to draw all this with specifications, they get a complete 3 marks. So you are marking them for the contour, that is the shape of the clock, or the whether it's a circle or a square. Second is whether the numbers are written correctly. And third pointing is for the hands in the clock. Then you come back to step 3, where you ask them the 3 words that they have. If they remember that, then you mark them accordingly. So coming to the management, we have the non-pharmacologically pharmacologic management, which is as equally important as the pharmacologic management. So non-pharmacologic is where we ask the family to have a routine for this patient. Now, because they are bedbound, or because they do not know what they want, most of the patients may end up being neglected, being, just in one corner of the house with no one to look after. But here we have to insist on having them wake up at a particular time in the morning, open the windows, tell them this is day, and close the windows when it is night. Have a clock in the room to tell them that the time is such and such, today's date is such. They remember or not, your aim is to try and work on their strengths that they have. Okay. And if they are able to mobilize, help them to go for a walk, or if they are wheelchair bound, take them out for a walk on a regular basis at the same time every day. Cognitive stimulation exercises are few of the exercises that can be done on a regular basis to stimulate their brain function. and caregiver support is something important. Now, dementia patients are not like heart patients or stroke patients, wherein we know that as they progressively deteriorate, they are going to pass away. Dementia is unfortunately a long-term, chronic, progressive illness, which can cause a lot of stress over the caregiver, causing caregiver burnout. So that's the reason why respite care is available for them. So please see that whichever patient you are seeing, also address the caregiver burden. Okay. Coming to pharmacological management, we have cholinesterase inhibitors like donepezil and rivastigmine. And for severe cases, we can also add memantine. Now, there's something called behavioral and psychological symptoms in dementia where the patient is unable to express what he feels. Say, for example, he has an abdominal pain or he has burning sensation while passing urine. He is unable to express that. And so it comes out as behavioral changes in the form of aggression, agitation, abusing himself or abusing the caregivers around him. Or it can go to the other extreme where he'll be completely drowsy or sober. So this in itself is another class, but then looking out for this and trying to find out what the patient has is important. Most of the patients with dementia can have um, either urinary infections, chest infections, or electrolyte abnormalities, namely low or high sodium, low or high potassium. So first, if you see that a patient with dementia has some behavioral issues, first you rule out infections and rule out electrolyte abnormalities. And if that is ruled out, then we can see what next to do. Otherwise, if it is any of this, you'll have to treat it accordingly. So communicating with patients is a challenge always, mainly because we ask something, they say something else. Sometimes the attender just leaves them with us and then there's no way to communicate. So the first thing to remember is treat them with a lot of love, treat them with a lot of patience. Use simple language, use a calm tone. They get agitated when you get agitated, and go slow, one idea at a time. Okay. And if they are anxious, if they are fury, I think validate their emotions. And as I said, be patient and give them some time. So coming to cognitive stimulation exercises, the most common ones that I do in the memory clinic, I ask the patients to do are puzzles, Sudoku, doing simple arithmetic problems, especially when they are good with those problems that are there in those Montreal and MMSE tests. Gardening, listening to music, reading and writing, learning a new language, discussing old photo albums, taking their old memories and, reiterating what has happened then. Social interaction. So most of the patients that we see, once they realize that they have a memory issue, they they refrain from going into the society into for family functions because they are scared that they may not be able to recognize them. But you'll have to encourage them, stating that is all right, but keep the family aware that people don't insist on why is his memory impaired, are you doing something about it, and let them not talk about it in front of him. But other than that, social interaction is a must. Okay. Flashcards are some of the specific cards that have pictures of birds, pictures of animals, pictures of flowers or fruits, and then give them a time of 1 minute and ask them, what is this? What is this? So each time we see that if they've done 10 today, probably tomorrow they improve by 11 or 12. Okay, doing other card games would also help. So the take-home message is dementia is not as simple as we think. It's not just simple memory loss. It affects their judgment, their reasoning, their ability to recognize people, and it is complex and challenging. Early recognition is crucial because it helps to improve the quality of life of the patient, and not just the patient, but also their caregivers. And communication skills and brain stimulation activities go a long way in reducing the progression to or delaying the progression to dementia, from cognitive impairment to dementia. And we have to support not just the patient, but their caregivers. And remember, you are not alone. You can always use a team. So in the community, what you would do is you can start with any patient that comes in with memory issues, start with the mini cog. If you think there's something is positive there and they're having issues with that, either refer them to a higher center where they can do a memory assessment, or you can yourself do the Montreal training or the MMSC and then go ahead for the imaging and then refer further. Okay, thank you.
Thank you so much, Archana. That's giving them like very useful solutions and feasible solutions that they can implement. Her slides will be shared, but if you still have any questions for her, you can put it in the chat. This is the last talk of the CME, but we have a panel discussion after this, which will be moderated by Dr. Diane, who's the Joint Secretary of the Alumni Association. So please stick around for that. I have also shared a feedback form like yesterday on the chat. So please, it would be really helpful if you could fill the feedback form so that we can give feedback to the speakers as well as curate it for the next time. So now I will hand over to Dr. Diane.
Hi, Anjali, am I audible?
Yeah, you're audible, Diane.
Yeah. Is the slides seen?
Yep, the slides are seen.
Yeah. So good afternoon, everyone, and welcome to this panel discussion at the fag end of our CME. So our topic for discussion today is on preventive screening guidelines and how to increase the uptake for screening in the rural setting. So we are privileged today to have with us a diverse panel of experts, each bringing deep insights from research, clinical work, and community health. So the audience for today, as we all know, you are the backbone of India's primary health system. And that is why the focus today for our discussion is to bridge gap between the guidelines and the real world practice. So let me briefly introduce our panelists for today before going into the discussion. Our first panelist is Sister Catherine. She's a scientist E, affiliated with ICMR Ministry of Health and Family Welfare, New Delhi. And among her areas of interest are public health and cancer research. Dr. Kiran Kulkarni is an associate professor, Department of Gynae Onco in SGMCH, Bangalore. Her areas of interest being preventive oncology, hereditary cancers, and fertility aspects in oncology. Dr. Sandeep is assistant professor in surgical oncology and at St. John's Medical College and Hospital with a specialization in surgical oncology. Dr. Merlin is our assistant professor, Department of Community Health. Among her areas of interest are occupational health, non-communicable diseases, and what catches her eyes is in the hobbies, financial planning. I think something that we all need in any setting in this world. Dr. Annie is assistant professor, medical oncology, St. John's Medical College and Hospital. And I think most of us already know. So without much further ado, let us start this panel discussion. And my first question is directed towards Sister Catherine. Sister, could you please briefly explain the current national guidelines or programs related to screening for non-communicable diseases, cancers, or infectious diseases that the rural doctors should be aware of?
Thank you, Dan, and thank you for this opportunity to speak. So, yeah. Regarding the national program for screening for non-communicable diseases in India, we are having the program was called as NPCDCS program. Currently, it is called as National Program for Non-Communicable Diseases. It is NPNCD program. So under this program, we are having screening for hypertension, diabetes, and 3 common cancers. So the 3 common cancers are oral, breast, and cervical cancers. So all this has been started in 2010, and in the beginning it was like piloted in 100 districts and 20 states of our country, and currently it is running in all states of our country and all districts of our country. So, but to be specific, I mean the reach of this program differs from state to state. It all depends on the strength of the health system of that particular state. For example, if you go to the south, the program is very strong under NHM. It is under the National Health Mission. So primarily this program is organized and conducted at PHC level or at the Health and Wellness Center, it is called as in the government sector, or currently it is called as like Ayushman Arogya Mandir. Previously it was like Health and Wellness Center, and now the name has been changed to Ayushman Arogya Mandir. So the screening happens for everyone above 30 years of age. So whoever comes to the public sector, public sector hospital, like a PHC or below that at an Ayushman Arogya Mandir, about 30, if anyone reaches there, the government facility is supposed to screen them for hypertension, diabetes, and cancers. So this is running in many states quite well, but I can't vouch on it. I mean, there are states wherein even though the program is there, it is not running like quite well.
That's very good to know, sister. So is there any data collection that is done by government agencies where our doctors, most of us are not working in the government run centers. So is there any way that our doctors can contribute to this particular data collection or screening? And if they can, then what is the modality to do it? And do we have any contacts that they can raise, they can go up to?
Currently, I mean, there is a system, there is a portal to enter the screening of cancers and all the NCDs. There is an Arogya Ayushman, one name is that I forgot the name of the portal. There is a portal to update, enter the data, but it is entered by the like CHOs, community health officers, are supposed to enter this data. Now there is a cadre in throughout India, like it is called as community health officers, CHOs it is called as. They are like not MBBS doctors, they are nurses, BSc nurses, or doctors from the other streams like Ayurveda or Unani or homeo doctors are there. They are posted in this health and wellness centers, and they are supposed to enter this data at a national level, and the data is compiled at national level. But currently this facility is not available at the private sector, but I can find it out, because wherever this program is, I can find out, and later I can let you know if there are any ways or means whether it can be access can be given to the private sector also, and our screening also can be added to it. That I can find out.
Sure. Thank you so much, sister. So for the audience, we would love to have questions from you too, and we will try to answer as much as possible in this session itself. And those that can't be answered, maybe we can reply on another mode of communication, probably through email. My next question to Dr. Merlin is, Dr. Merlin, you have a background in community health, and you've seen patients at grassroots level, not necessarily patients, because prior to screening, these are just regular people who need to be spoken to. In your opinion, what are the key barriers to preventive health screening at grassroots level?
Yeah, so you're right. So we all know how important it is to screen at the community, but we already know that it will reduce the need for aggressive treatment, and it will reduce the cost, and overall health of the patient is also improved. But still, in my understanding and in my interaction with the patients, what I can see is that there are 3 sets of barriers, which if I can categorize them, it can be at the individual level, it can be at the provider level, and then it can be at the systemic level. If you're thinking about the individual level, then for the individual per se, the lack of awareness, especially in a rural area, the person is not aware that he needs to get screened. Like there is, as the sister rightly mentioned, there is the program where everyone above 30 needs to be screened for diabetes and hypertension, but the awareness is not there. Most of them think it as a geriatric illness, so they do it when it happens at 60. Then secondly, one thing is, in the rural area, they don't have fixed timings, and they don't have days off from work to come to the health center and get themselves screened. So that will be another individual barrier that we come across. And for certain diseases like cancer, they are very, it's quite stigmatizing for the individual. So even when we conduct cancer camps, screening camps, like for cervical cancer, we recently had a patient who was diagnosed to have, not diagnosed, but with pap smear, we caught her early. But then she was very reluctant to seek further treatment because she was very stigmatized. And what will the other villages do if they found out about it? So these are major individual barriers that we can see. And for elderly person, it is even more difficult because they need caregivers who can take them to the hospital. So those kinds of things which occur. Then when we're looking at provider based, it would be one would be definitely the language. So most of them are talking in their local language, while the provider may not, the doctor may not know or may not be able to communicate. So there's always the communication issue which happens there, and the lack of trust, because a lot of people don't trust in the modern system of medicine. So they may not be, even if we diagnose them to be hypertensive or diabetic, they may not be trustworthy. They think that we all come there just to find out so that we can give them medicine. So they may not be accepting what the modern system wants to talk about. And also there is some kind of discrimination that happens at the rural areas. So they feel that they are discriminated against their social class or against their caste and so on. So that is some of the provider-based barriers. And systemic, definitely what we see in the rural areas, there is in the public health system is pretty weak, and it's different in different states. But certain states, the primary health centers and sub-centers are present, but they're not very well equipped. So even if there is a center per se, there is no doctor, there are no tests, or there's no lab available. It's just run by one person. So that gets overloaded. And also another systemic thing is a lot of this screening and activities, community-based screening, opportunistic screening, all this has to be done by the ASHA worker or the ANM. Now the ANM is already overburdened with MCH work, with maternal and child health care, with immunization, and now we're asking her to do non-communicable disease screening as well. So it's an overwhelming experience. So it may not happen the way we want it to. So these are certain barriers which we noticed.
And how do you, I mean, one important thing that you touched upon is communication.
Yes.
So to communicate to them is something which is very difficult. So do
Yes.
we have any strategies that we have used in our centers in our rural areas, or that you have come across, that can be helpful to our people? Because ASHA workers and all are not at disposal of our doctors over there. So
Yeah.
any innovative strategies or any communication strategies to increase screening?
Yeah, so we can use language. It's difficult to learn all the languages that the patient comes up with. So what we can think about is using pictures and posters, and using technology, like using videos, making videos. So we have done those kinds of activities where we make short videos which are not required. You don't need to play them in any language. You just show it to the patient and then they understand. Or even pictures where it's shown to them, like for example breast cancer, the disease pathology is shown to them, and then they understand about it. So there are ways to go about it. The best way would be definitely to learn as many languages as possible, but if not, these are some other roundabouts.
That was wonderful, the video and audio language techniques. But I can assure you that all the sisters and all our doctors in rural areas, all of them know the most localist of language that is available. That is really wonderful, and hats off to them. The other thing that you touched upon was about cervical cancer. I'll direct this question at Dr. Kiran. Ma'am, what are the recommendations at present for cervical cancer screening? And what could be a few cost-effective, low-cost cervical cancer screening techniques that can be implemented at PHC level, that is our rural areas? Also, anything about the HPV vaccine for them?
A very good afternoon, and thanks for this opportunity. Answering the first part, as far as the recommendations are concerned, all these years we were, banking on the international recommendations for cervical cancer screening. But the last couple of years, we have our own Indian guidelines when it comes to cervical cancer screening. We have our FOGSI, that is the Federation of Obs and Gynae Society of India, which has come up with recommendations based on the resources available. So there are low resource setting also recommendations, as well as where everything is available. So the basic screening, whatever age for screening, starts with 25 when it comes to the cervical cancer screening in India. World over, they say 21 onwards. But in India, we have recommendations starting from 25 years. We have two modalities which can be done starting at 25 years. That is the pap smear or cytology. And then we have the VIA, that is visual inspection with acetic acid. Both these can be done once in 3 years. So VIA usually is good up to the age of 50 years. It is of limited value in women who are postmenopausal. So best thing is the HPV DNA testing. Very frankly, for all age groups, the recommendations in our country for HPV DNA testing starts from 30 years. Even primary HPV screening is there, wherein you can start from 25 years onwards. So HPV once in 5 years, cytology or VIA once in 3 years, up to the age of 65 years. This is the current, recommendations for cervical cancer screening. And coming to the rural areas per se, wherein there is lack of facilities available for cytology or HPV DNA testing, VIA is a very simple method which can be implemented in the rural areas. But the glitch with the VIA is that it is slightly less sensitive when it comes to when we compare it with pap smear or VIA. The best test is HPV, which has a very good sensitivity and specificity. VIA lacks sensitivity, but it's fairly specific. So for the rural setting, that is very much a doable thing, low cost thing. But then we need to train the nurses. The challenge is that it is a subjective, test wherein the nurse or the ANM who is trained to do it does the VIA, which is just application of 3 to 5% of acetic acid onto the cervix for a minute and observing the changes which occur after that. So based on that, we deem the test as either VIA positive, which means it's abnormal, or VIA negative, which means she's free of any problem at present. The challenge is training. I think VIA, we all have been, we know about it since ages. It is there. The government is trying to actually train the ANMs, but there is hardly, even less than 5% of the ANMs are trained, I can say, to do the VIA. It's a very simple thing, but at the same time, it has been, not so successful when it comes to implementing it at the grassroots level. So one more thing at the grassroots level, which actually does away with these difficulties, what the VIA has is HPV, low cost HPV. We are now slowly coming up with indigenous tests which cost much lesser, and HPV has the best sensitivity and specificity. And one more new thing what we have been doing now with is self-sampling. The biggest, I think, barrier is what we were talking of. When it comes to cervical cancer, women do not turn up for screening. You may give the awareness, you may give the test free also. Despite that, women don't come because of various reasons. So but to overcome this, we are involved in a project, a multinational project, wherein we are doing self-sampling HPV. So that has kind of been a very, good experience. The women are so happy with it. It's like they don't have to leave their confines of their home. At their own convenient time, they can collect the sample. And that the challenge here is, of course, transportation of the sample. But that is one good way. If we are able to come up with a low cost self-sampling HPV, I would say that is the best way forward. But yes, we need to still work out the logistics and the cost involved. But till then, VIA is a good modality to understand or do in a rural setting. So, and we are happy to actually, we had communicated with Sister Blanche earlier that we are happy to train the sister doctors who are serving in these rural areas to do the VIA, and we are available on say on call, or they can send the VIA pictures to us, and we can as well help them out in kind of interpreting that. We also are involved in a project wherein we are actually part of a study which is looking at an app which helps the ANMs or healthcare workers at the grassroots level, wherein the challenge in VIA is interpreting whether it's positive or negative. Okay, so that app helps in understanding whether it's truly positive or negative. So these are the simple things that I think in the future with AI and everything, we can help out even in the rural areas.
Sure. That's so good to know. That's so good to know, and we look forward that for some partnerships to happen so that we can train as many as possible for the VIA test. Thank you so much, ma'am. My next question is towards Dr. Sandeep. And sir, so please enlighten us what are the simple red flag signs to watch out for especially with screening for cancer when a patient walks in to a regular OPD, and as a continuation of that, what are the recommendations for breast cancer screening that rural doctors should be aware of?
Good afternoon, everyone. First of all, regarding the red flag signs, whether you do for the screening purpose or generally, so for all the malignancy point of view, from head to toe, if you consider, see, there is a oral ulcer which is very chronic. Chronic in the sense for the oral ulcer, if it is more than 2 weeks, which is not healed by medical management, and or it may be the skin ulcer or the wound which is about more than 3 months old, and that is again which is not at all resolved even with the medical management. And apart from that, there is a history of dysphagia or change in voice or the hoarseness which is persistent, and chronic cough which is again will be like more than 3 months, and there is a change in bowel habits, and bleeding PV or history of black colored stools, what we call it as a melena. And in case of the postmenopausal woman, if there is a again there is a history of the PV bleeding, onset of the PV bleeding or the spotting, and in case of the skin malignancy, there is a change in the warts or the pre-existing warts or the mold where there is a bleeding or the pain, there is increase in the size. So all these are simple red flag signs we can ask ourselves to the patient, or the patient may come up with these symptoms where you suspect malignancy particular to the organ. And regarding the breast cancer screening or the awareness from the in the rural point of view, see, it is for the rural or the urban, most of the women are not aware of the breast self-examination and the clinical breast examination. So clinical breast examination will come to us with like the physicians or the doctor, maybe at the PHC level or in the urban setting, whatever it is. So breast self-examination, I want to share that few detail because so there is a data which says that if the woman is having the breast self-examination occasionally or the periodically and the regularly, the chances of identification of the tumor size and the stage also differs. That means if the woman is doing occasional breast self-examination, the chance of getting the tumor size is higher compared to the regular examination, breast self-examination. Now, the breast self-examination, if we talk, it is a very broad term. What is actually breast self-examination? Every woman should be aware of, and the treating physician at least should be communicable about the things which are very important in case of breast self-examination. Just palpating bilateral breast for herself, it is not a breast self-examination. So there is a protocol. So every physician, even the rural setting, they should educate the woman whenever they do the screening for the breast cancer, even if they have not found out the breast lump. So what is breast self-examination? So in the for the right breast they should use the left hand, and for the left breast they should use the right hand, and it should be from all the quadrants, from the collarbone or the clavicle to the ribs below the breast, and they should raise the hand or the arms above the shoulder to check for the axilla also. And it always, we know, the examination starts from inspection, so the woman should be, I mean, able to inspect herself in front of the mirror, which most of the women won't do. And even after that, the examination, so for everyday practices, it should be from the light touch, then with increasing pressure in all the quadrants. Along with that, finally, the breast self-examination ends with the pressing of the nipple areola complex to express the any bloody discharge. So this is the complete detail of the breast self-examination for every rural doctor should be aware of whenever they encounter the woman for the breast screening protocol. Thank you.
Good. That's very good to know. Is there any visual aid or anything available online that they can show them in visual aid or something like that?
Yeah. See, even for the Indian government also has released some small protocol which says different picture of how to do the examination herself. So that also the picturization also can be shown to the woman. So that is one thing, but they should be explained in detail instead of telling these things, because it should go to her mind completely for the complete examination.
Good. Thank you so much, Dr. Sandeep. Now, Dr. Annie, this whole cancer itself is such a big diagnosis, and in the rural area with the family, with the financial constraints, it's a huge thing. Is there, I mean, since you're in the medical oncology department and you have seen patients in AIIMS who are referred from different areas of the country, and do you have any mechanism for early referral that can benefit these patients, and also for follow-ups? So once the whole therapy and the treatment is done, like how Pallium India has telemedicine for palliative care, is there anything like that for oncology per se?
Hi, Ryan. Thanks for this opportunity here. Yeah, very relevant stuff discussed prior. All the panelists have given the words of wisdom, and I accept that once, right now we are still in that stage when people think that the diagnosis of cancer is like a punishment. So the stigma in the rural area is highest, because once they think that they have been diagnosed, there is no way out. That is the first thing. They think that they are going to die. That is the first thing that the patients come with. And coming to your so important is on the community level to actually percolate down that it's not the fact, and giving them live examples, like giving examples of their neighborhood, someone who has been diagnosed, treated, and is a survivor helps. So how we used to tackle this problem is, whenever a new patient was diagnosed at AIIMS specifically, there were survivor groups. So there are actually survivor groups for different cancers available pan India actually. So if we about your question about the telemedicine stuff, there is especially in Kerala, there is something called OncoNet, which is a telemedicine center which they can, and even in different states this is coming up slowly. So about telemedicine, even Actrec in TMH, Mumbai has a telemedicine facility which can be utilized. So that is one thing. And about the patients who come in from rural area for treatment, first of all, we have to, counseling. Just treatment is not enough, actually speaking. The counseling is important because the compliance is very, very important. Many a times, early stage cancers which are curative, they leave thinking that I am not going to survive. They go back and then they come to us in a locally advanced or a really bad stage 4 status when it becomes completely palliative. So as in the previous talks as well, they said time is the key point here. Even cancer gives you that window where it is curative. If you really catch on to that, then it helps to get the treatment done and also be a survivor. Now, the problems that we face when the treatment is going on is the first treatment, when we initiate the first cycle of chemo. Suppose for a breast cancer, considering for females, it is the leading cause, of malignancy. First chemo cycle is the most, the ladies are very anxious. They don't know what will happen after that. So what we do is we make them speak to the survivors of breast cancer. So when they speak to the survivors, they know what are the complications they are about to face, how long the treatment is going to be, and how to overcome the complications. So this is one aspect, to help them speak to the survivors. They themselves have some Zoom meetings or some telecommunication by which the patients actually help out the other patients. And about the cost factor, in the rural areas, many of our doctor sisters are there. They should have actually a list of government centers which are affiliated for cancer treatment, because many of them cannot afford the private setup. So it is important, like in each state, there is some government setup where the chemotherapy is free, actually free. I'm not talking about the targeted therapies, but chemotherapies are free. And actually Ayushman Bharat has been implemented in quite a few places, which has helped even in private sectors to get it free. Like in Andhra Pradesh and stuff, Arogya Shri is helping, where they So all the rural doctors should be aware that yes, this center close to my place has this scheme available, because once you start the therapy, you want them to complete the cycle because it is curative. I'm talking about all the curative malignancies, like as Kiran ma'am specifically said, cervical cancer early detection helps in cure. I'm talking about cure rates here. Breast cancers are curable, and the chemotherapy in many of the scheme all are covered. All 8 cycles are covered. Also the febrile neutropenia periods that they have in between, that is also covered in that schemes if it is affiliated to that. So because finances is something which always is a burden for our rural patients. So once you sort out that, and there are NGOs also now, NGOs are coming which is specific to cancer patients, taking care of the finances, their logistics. There are many in every state which is coming up. I can give you an example of Sachin Sarcoma Society, which is just for sarcoma. It is a pan India. They can log in. Everyone has a phone right nowadays. Everyone has a smartphone. Now, if you are logging in, and Sachin Sarcoma Society is one of the survivor groups where actually it was founded by a survivor, a sarcoma survivor, and they're helping out. And they have, weekly meetings where they, even in, this is, I'm talking about the rural area as well. They have a Zoom meeting because we are involved in giving the talks. So this is just one of the survivor sarcoma societies. Like that, there are breast societies, there are other societies. Now India is also coming up with each specific organ specific way of handling all the doubts that the patient is. So apart from the rural doctors also, when they come to them, it should be a optimistic counseling that should be given. What I have faced is, even at the ground level, just the diagnosis says that it is incurable. So that ideology has to slowly fade. And of course, educational sessions about how things can be taken care of, it is curative, how to identify the red flags, when to come in, all these things are very, very important. So this is how I think we can go forward, and strengthening our rural system will help in the way forward, because everyone is not able to come to the urban center. And recently, actually, in Karnataka itself, recently, if you have seen the newspapers, the Chief Minister has inaugurated district level chemotherapy daycare centers, which is affiliated to the government hospital. So like this, there will be state-wise, which the government is planning to implement to enable the treatment of the patients who have to travel a long distance to the cities to take their chemotherapy. So this is something which is recently come up, because the government of India has been going into that hub and spoke model. So from the like the tertiary care center, there will be district hospitals that will be affiliated to give the treatment. So this is just one example I'm giving, that Karnataka has just launched that, and it will be implemented probably in a month or two, something like that.
Sure. That's wonderful to know. The other thing is, there is one that funding that is available from the government and the free healthcare. What is your experience with online platforms like Impact Guru or one of these funding platforms? Do they help too, or is it like better to stay away from?
Actually speaking, it may have started with a very good intent to begin with, but some of them actually have scams also. So you should be really aware if you are in a private setup. Like we too get certain patients who try to tell that put it on the Impact Guru and they'll help out. But it started with a good intent, but like as the day progresses, that it always becomes into a scam. So always get it cross-checked, because many of my colleagues pan India have now refrained from telling them directly to go into the Impact Guru things, because you should people donate, but actually the money does not go to the patient. Correct. So correct. This is what is happening lately. So you'll have to really see how trustworthy that app is for generating funds. Because like in John's itself, now we are trying to get a fund for cancer patients. So this how we do is telling our cancer survivors, through our cancer survivors, we are telling them that if you can donate, who are quite well off, they can donate to the funds, and that's how we are creating a corpus. Some of the sites may be trustworthy, but you have to take that with a pinch of salt. always, because many have burnt had their hands because the doctors had to give the letter. And my colleague somewhere in Delhi and also in Vizag, they have refrained from doing this because the authenticity is nowadays going. So we'll have to take that with a pinch of salt.
Correct. Thank you so much, Dr. Annie. Whenever this detection of cancers or any non-communicable diseases happen, it's very important to maintain a registry. And I think Dr. Sandeep, if you can just tell us about the cancer registry that has been started in St. John's. Dr. Sandeep?
I may take that question if Dr. Sandeep is not available.
Please, ma'am.
We have established a hospital-based cancer registry with us running for quite a few years now. And even Department of Gynae Onco is a part of it. And it's doing a wonderful job. And it's everything. It's now notifiable. We all know since many years a notifiable disease. So this now, apart from the hospital-based cancer registries, there are population-based cancer registries as well. And the move is to have rural cancer registries. Okay, so the numbers may be small, but then that helps, I guess. I mean, so each area can be mapped for what type of cancers, how many people in that particular area or district are having what type of cancer and what challenges they go through. That may help in understanding. So Dr. Rakesh, surgical oncology is in charge of the hospital-based cancer registry in John's right now, and they're doing a phenomenal job. Yeah, that's about it.
So, ma'am, is there any way that they can, that our maybe Sister Catherine would like to add something? Yeah.
Yes. This cancer registry, the hospital-based cancer registry and population-based cancer registry is run by ICMR in India. So the ICMR is supporting the registries with staff and with funds also if we wanted to register under them. And nationally, it is the data is collated, and the data is available in the website. So if we wanted to take the data of the type of cancers, the age groups, then the stages of cancer regarding the treatment, the survivorship is not there. So all this data is available in the NCDIR, this is a cancer institute in Bangalore, as others will agree. So the data is also available, and we can collect. I mean, we can also use that data for the purpose of research and everything. Yeah.
Sure. Thank you so much, sister. The one question on that one of our participants has asked is there, I think directed to Dr. Kiran, is there any long-term side effect of HPV vaccine? Because parents hesitate to give their daughters because of the misinformation, the many side effects that they hear about. Dr. Kiran.
Yeah, this HPV vaccine has been a part of a controversy. I think all new vaccines, as we know, we have seen with the COVID as well, they kind of run through that phase of dilemma or controversy and then come out of it. So, but now we have enough data. It's been close to 2 decades that the HPV vaccine is available now. And with the latest nanovalent also entering into the scene and the Indian vaccine also available now, a lot of research has gone into the safety aspect of these vaccines. And with more than millions and millions of doses given globally, it is now proved that whatever these, false news regarding it being unsafe, they are all not true. It is a safe vaccine, can be given. I think any vaccine has a very small percentage of, having adverse effects. So that has to be explained, but by and large, it is safe. I think the bottom WHO has actually given out a statement saying that it is very safe to go ahead because of these, false news that it is unsafe and causes so many adverse effects and so on and so forth. So the bottom line is that it is a safe vaccine to go ahead with.
Yeah, there is a plan to add the vaccine to the national program. So in the recent budgetary committee meeting, there is a decision from the national level to add the vaccine into the national program. So I think in another 2 years' time, it will be added into the national immunization program.
Thank you so much. Yeah, I can. Thank you so much for this discussion. This has been a wonderful few minutes. This was a very grounded discussion. And thank you each and every member of the audience. You are the backbone of the country's health system. And this panel discussion was directed towards you. We salute you all. And to the panelists, you have been wonderful, wonderful knowledge. Many things were new for me too. Thank you so much for being on this CME. I don't think words can be enough to thank you. Thank you so much. And over to Anjali.
Thanks so much. As Diane says, thank you to all of you for joining and for, opening our eyes to a lot of things that we didn't really know were available in our country. And also thank you to Diane for moderating this very, very well and asking very, very pointed questions so that I think that's why we don't have too many questions in the audience. I think he's managed to cover most of them. So now actually we come to the end of our CME. So first, I'd like to thank every single speaker. They were all very, very enthusiastic, and everybody agreed and immediately and presented really well. I think all of you can agree with me, and I'm sure the feedback form will reflect that. So please fill the feedback forms. I've pinned them on the chat. And thank you to all of you. It was really nice to know that throughout our sessions yesterday and today, we had over 80 to 100 people for every session. And it was very nice to know that it's useful to you. And we hope we can do this on a regular basis. If you can get back to us with what sessions you'd like, that would be great. Then we can curate it for the next time as well. And of course, thank you to Prithvi, without whom I wouldn't have been able to do this, and to Diane. Thank you so much. Diane has raised his hand. 1 second.
No, I put it down. I put it down.
Okay. All right. Prithvi, if there's anything else, or Diane, if there's anything else, otherwise we'll close.
We can wind up. Thanks, everyone. It was fantastic 2 days.
Yeah, Anjali and team, thank you so much. It was great listening and being part of it. A good job. I think.
Thank you, sister.
Yeah.
Thank you so much, Dr. Anjali and Diane.
Thank you, Kiran. Thank you.
Thank you, Diane.
We can actually have a summary of each session, and we could help out with from each one of us a short thing regarding recommendations from each of us, and which can be circulated later.
Sure. That's a good idea. Thank you.
Yeah,
thank
you.
Your certificates, we'll work on it and we'll send it to all of you over the next week or so. We'll send it to you by email, whoever's registered. Yeah. I think somebody else has a question. Okay. All right. Thank you so much.
Thank you.